to start the day, I'm going to ask my friends here at the front table to join me. We're fortunate to have so many brilliant, dedicated people working in research and seeing patients in the field of LHON. And today we have three of the best from the US and Europe here on our scientific panel. Usually, they're introduced by a long biography of their scientific and medical achievements. But today's panel is really all about from the patient perspective. So really, rather than reading you their biographies, what I'd like for them to do is to tell us about themselves from the perspective of LHON. How long have they been working on it? How many patients have they seen? Things like that. So I'm going to move this mic over here, and I'm going to ask
Sure. Hi, my name is Alfredo Sadun. Before I go any further, I should mention that Lissa is much more than the moderator at this session. She's a key organizer in the field of labor. She organizes not just patients, but she organizes scientists and clinicians and even pharmaceuticals. And I hope soon she'll be organizing the legislator. She is more than that. She's a real inspiration in the field. And I recently had the occasion to introduce her, so I figured out the best way of understanding her. She is a mom. Not just a mom of somebody with the disease Leber's, but a mom to the entire organization and to the entire process, and she relates that way. So thank you, Lissa. I am a neuro-ophthalmologist. That means that my education, which in my case involved more than the usual amount of time spent doing science, but it involved also residency in ophthalmology and then a fellowship in neuro-ophthalmology. But very shortly after that, and we're talking about a long time ago, 35 years ago, I found that I was truly interested in one tiny, tiny little structure. And in fact, I've already misled you. It's not a structure. The optic nerve is a composite of 1.2 million fibers, an important distinction we'll get to later, I'm sure. And then the most mysterious, remarkable, and devastating disease, I think, of that is Leber's. And so I began my great interest in Leber's about 35 years ago. That's certainly the basis by which I've made many new important friendships, the basis for which I've seen many patients. And it has been both an intellectually fascinating area because so much progress has occurred, an exciting time to be in the field, but also an emotionally devastating area because it can be difficult. But we have made enough progress that it's becoming less difficult all the time.
Okay. Is this working?
Yes, you share that one. This is ours.
Is working?
it should be. There's a button on the side. Click.
Maybe we have.
Let me just
Must be all right.
Didn't I tell you she was a mom?
So, my name is Valerio Carelli, and I'm a neurologist by training, but also a geneticist. So, I got involved in with Leber's in 1988. So, I'm literally born with the first mutation when the first mutation was described, professionally born. And since then, because at the time I did my thesis for the degree in medicine on the first family with Leber's in Italy. So since then, I have been working very intensively on Leber's, and this is my main focus, even though I see all kinds of patients with mitochondrial disorders, other kinds of optic neuropathies like dominant optic atrophy and so on. And over the years, at some point, I spent 3 years with Alfredo in Los Angeles, working with him, and over the years, I got to know also the youngest of us three, Patrick, and I guess we have a nice group of people, scientists and clinicians now working all together in a very coordinated way. And that's the best way to get important results. And I'll pass you the microphone.
Thank you very much, Valerio. My name is Patrick Yu-Wai-Man. Like Alfredo, I train as an ophthalmologist and subspecialize in neuro-ophthalmology. I've been involved with research in mitochondrial diseases for the past 15 years. I initially started doing my research actually with the Newcastle mitochondrial group on Leber's optic neuropathy, trying to understand the genetics and the clinical features. And actually, I stayed. I did my PhD, did my fellowship training, and I have the chance to work with a fantastic group of clinicians and scientists in Newcastle working on these mitochondrial diseases. And also more recently, I've been running a specialist optic nerve genetics clinic at Moorfields Eye Hospital in London. So I've seen the transformation in Leber's optic neuropathy over the past 15 years. We're moving from the basic science towards the translational side of things, which to me is really exciting because, let's face it, treatment options are limited, and that's why we're doing all the work to try and help patients and improve the visual prognosis.
Sorry, I forgot to mention that I'm working currently at the University of Bologna, and I have clinical and research laboratory over there. I think we are ready to start.
Keep that over there. So the way the format's going to work today is I've got a series of questions that I'm going to ask our panelists to discuss, and I'm going to ask them to sort of work through the issues that are of interest to the LHON community. So we'll go through issues related to being affected, and then we'll go through carriers, and then we'll go through research. And so as we work through these different areas, I'm going to be asking them to talk on a topic, and then I'll open it up to the floor for questions, and we'll have a couple of volunteers are bringing microphones around to take questions that we didn't cover. So the first question that I'd like the group to talk about is to talk about, imagine you have a patient walking into your clinic tomorrow, and they're a typical person, so it's a male, 11778 mutation, age 15 to 25. And what's the typical natural history of the disease for that person? What should they expect?
First of all, the word typical is ideally used here, both because we can talk about what is typical, but also because from a medical science point of view, when it's typical, we know what to do. When it's atypical, we sort of have to throw up our hands and say, let's think. And we have to do a lot of other things. But many of the patients in this room were such a patient and have come to visit me in Los Angeles, which is, I forgot to mention, where the Doheny Eye Institute is. We're part now of UCLA. And what would happen quite often in this country, typically, is somebody would come in perhaps after his freshman year in college. And the story would be that he had no idea there was a family history of an issue, although after some thinking, there was a great uncle who had had some loss of vision, but they didn't know from what and never carried the specific diagnosis. In college, he was fine. He saw well. We're probably talking about an 18 or 19-year-old here. And then somewhere, perhaps in one particularly hot period, which is not hot temperature, but likely to have an effect, which often is after they've joined a fraternity, they have been doing maybe a little bit more drinking and smoking than usual in association with a college experience at a fraternity. And they lose vision painlessly in one eye. And having lost vision in one eye, they go to the infirmary, where the infirmary says, are you sure you've lost vision? Your eye looks awfully good. When are final exams now? And they may have a little struggle to say that it's very real. So then they finally will call the ophthalmologist in. And the ophthalmologist invariably makes the mistake of saying, since I don't see anything wrong with the eye, and you say that you don't see, and I believe you, it's probably this common disease called optic neuritis. And then they will tell the patient, good news, bad news. The good news is that the vision gets dramatically better. You'll come back. The bad news is you probably have MS. Now, obviously, this is all not true. And your MRI will show that. And so they come into the hospital, they get the MRI, and the MRI is perfect. Well, we'll do a lumbar puncture, that'll show it, and that's perfect. And they go through a series of tests, all of which are negative because they don't have MS, until the second eye gets involved, maybe a month or two later. With the second eye being involved, they finally reach the level that they say, you better go see a neuro-ophthalmologist who specializes in diseases of the optic nerve. And the neuro-ophthalmologist usually takes no time in knowing what the disease is. It is so specific and so characteristic when typical the particular features that will be seen when you examine the patient, the nature of the vision loss, the pattern of the optic nerve involvement, that the diagnosis is almost certainly going to be made then, immediately. However, to be on the safe side, the neuro-ophthalmologist will get the blood test, and that's when it'll come back if it's 11778, which I guess our sample patient has. This is not the end of the story. It used to be, and that's why the chapters are somewhat misleading. Not only is one eye involved and the other eye then gets involved, but things continue to either deteriorate or maybe get better now that we have some therapies. And at this point, maybe I should turn it to my co-panelists.
Well, should I say what we do?
No, I just want to stay on the natural history. In other words,
Okay.
so there's a crisis and the vision loss happens. Now, if nothing is, there's no intervention, if there's no intervention and there's no treatment, what would happen to that person for the next 10, 20, 30, 40 years of their life? Did the degradation happen and they're stable? Because there's a lot of talk about stable, or is there any ongoing change if there's nothing done to intervene?
Well, let's say that on average, the visual loss goes down quite rapidly. Depends on the cases, but let's say that within the first 6 months or so, most of the vision loss occurs. And we now have also data from OCT studies showing that it's actually true, that that's exactly the time frame where most of the loss of cells also occurs. And then obviously you get some stable period. Some people calls this nadir, which means the lowest visual function. And over the time, there are different degrees of possible changes. In some cases, the change is just due to adaptation. So the patient learns how to use and maximize the use of what is left in the vision. So apparently he recovers a little bit, but this is just because he learns how to use the areas of the visual field where still there is some possibility to go through the scotoma, through the fog or the black, depends on how this is described, and maximize that. Other people on a variable timing, which could be from the end of the year until very late, until even, I have seen people recovering some vision after 5 years or so. And this, I would call this second event a natural spontaneous recovery of vision, which is not adaptation, is truly some fibers which are left in the eye, in the cable, actually in the optic nerve, are able to recover the function, and so the scotoma would shrink or would open some windows through which the vision can go back in a more efficient way. And there are very variable numbers, statistically speaking. My experience is that about 20% of people with either the 11778 or 3460 mutation may experience that spontaneous recovery. The ratio is much higher with the 14484 mutation. So there is a difference between the mutations in terms of capability of recovering. Now, once the recovery is done, then you have a stable period. So the so-called chronic phase is essentially stable. If you're not lucky that you got some vision back, you're stable since the end of the first year, and usually that lasts the entire life. Then maybe an apparent worsening may happen, but this is going to be age-related. Each of us, at some point over the lifetime, we are losing some fibers from the optic nerve because of the aging process. And obviously, if you start losing fibers from 1.2 millions down, before you reach a symptomatic expression of this process, it takes a long time, or you may not feel anything wrong, but you're losing in age-related way some fibers. But if you start from very few fibers, then obviously if you lose some of them, that's going to be perceived as a apparent worsening. So this could be happening in the late stage of life. And frequently, if the vision loss is very low, this is something that is very difficult to measure. So it's most that people will tell you something is slowly progressing, which again is not a progression. It's the overlap of the aging process on the chronic phase. At least that's what I think. So that's pretty much the natural history if the patient is not treated, and obviously it might happen that if the patient, because of vision loss, has a social behavior where it gets very stressed, smokes and drinks, maybe he was not smoking before and he starts smoking after that. And so if you overlap other risk factors and toxic exposures and so on, then possibly the disease could become more severe than the natural history. But otherwise, so the entire problem here is how much fibers are left at the end of the active phase. So at those 6 months after the beginning, between 6 and 1 year, 6 months and 1 year, how much anatomically material fibers in this cable are left, it will produce the different outcomes. So if you have enough, you probably will have some degree of recovery, spontaneous recovery. If you have really, really low, unfortunately, it will stay low and the visual function will not recover literally almost anything.
Excuse me, can I just ask us to take a step back here? You know, I know it sounds bad to talk about anatomy, physiology, but we've touched on enough of that I think is important, which is that as a shortcut we talk about the optic nerve, but it really isn't a structure. It's 1.2 million fibers. Think of a cable between a camera and a TV set, and that cable has got wires in it, and there's 1.2 million of them, each independent of the other. And they're different sizes. And the ones that have to do with your central vision are the very smallest. And as we move out from the center, as I would look and move my hands out here, the fibers that would do the work for that get bigger and bigger and bigger. And the fibers that see way off to the sides of my vision are the biggest. And the disease starts small and moves to large. So that the patient who has had, at 3 or 4 months, most of the vision loss, it's true that they've had most of it in terms of most of the fibers, because there's many more of the small fibers. It's true that they've had most of it in terms of what he perceives, because most of us really care mostly about what we're looking at than what's out in the periphery. So as many of you already know, if you want to go explain to other people what it's like to have it, it's like having something blocking the middle of your vision, smack in the middle. And so what Dr. Carelli was referring to is this what seems to be a little bump up in vision, maybe 3 months later, is people realizing, well, I can do better if I face differently, or actually usually face above where I'm looking, so I can sneak a peek underneath that big central block. It's not a real improvement, it's just learning to work around the obstacle. And it's hard for the doctors to appreciate, because what do the doctors measure? Visual acuity. And where do you do visual acuity? Look at the eye chart, they say. Well, you're putting your hand right in the middle. The very last thing you can do is at that stage is visual acuity, but you can still get around, you can still see from the sides. So that both patients and doctors are psychologically blocked from measuring. Once we have lost that middle part, we don't really have a good sense of that. What do you use when you recognize faces? The center. When you read, the center. When you drive, and you have to pass the eye exam, the center. So it's not necessarily true that it stops happening out here. It just goes to the place where it's hard to measure. Now, I think that what you said about aging is certainly important and true. I'm not sure it's the only thing. I think this center to large process tapers off but may not stop. And unfortunately, we both, I'm sure, have patients whose vision loss is measured as counting fingers. You can see 2 fingers out here on the side, and that's pretty bad. But that they don't come back, but you see their uncle come in to see you, and he's 65, and his vision loss is light perception. It's worse. In terms of just general things, I do recommend it because it makes common sense. But frankly, we don't have clinical evidence that being healthy, exercising, and eating right is a good idea. But I do advise you to do those things. There's good theories behind that. Again, even though we don't have a study that proves that people who eat their vegetables do better than those who don't. I think they do.
Any comment?
Yes, as Alfredo mentioned, clearly the most important thing is to avoid smoking, which is a very strong risk factor for carriers of the LHON mutation to lose vision, and certainly there's a number of studies that have been published now strongly showing that smoking is a very strong risk factor. So we have to be very dogmatic about this, because this is one of the risk factors that you have control over. I think the other risk factors, some of them are anecdotal, but there is also some evidence that head trauma could trigger the visual loss in Leber's optic neuropathy, and it seems very sensible to avoid contact sports that will put you at risk.
Can I mention, we've been talking a little bit about triggers, and yet I want to talk about an affected person. Is everything that you just said true for affected as much as carriers? Because, for instance, with the medications, I know there's a lot of discussion in the patient groups. Well, I'm already affected, and so if it's a trigger, it's not my issue. I'm already affected. Does that matter?
Very much. That's the mistake of thinking of one optic nerve instead of 1.2 million fibers. And in the first year, as Valerio has alluded to, there's a certain number of fibers, the smallest guys, they're dead, and fibers can't grow back. This is part of the brain that does not have the capacity for regeneration. And there's a number of fibers that are so big that at least for the moment they're not at risk. But the ones in between, let's call them the middle guys, are sick and dying but not dead. Our treatment, of course, is mainly aimed at saving those guys and getting them back. But even if we weren't talking about treatment, if we're just talking about the natural history, you can lose more fibers. And so I strenuously object to anybody saying, well, it's all gone, it doesn't matter. It matters, and you don't want to be in a position of regretting it later.
Well, maybe one more point nobody touched is about exercise. I know that affected people, in particular males, there is a sort of a psychological reaction, and they dedicate themselves to a lot of heavy exercise. They go to gym or they run very demanding sort of special sports. It's not proven. I'm sure that exercise is a good thing in general because upregulates the mitochondrial biogenesis, which translated means that you make more mitochondria because you're exercising. So you're putting the entire system to a higher degree of compensation. However, too much exercise, and the line that we should draw between too much and good is very difficult to locate. But too much exercise could be a boomerang, could be something wrong to do. And it's a matter of fact that I have a bunch of male affected people, one swimmer, one lifter, and so on. They do a lot of exercise, and they're very severe. They didn't recover anything, and they're very severe. So it's maybe just a gut feeling, but we should think about physical exercise as something that should be done in a meaningful way, never being an extreme sort of activity. I understand that sometimes people can get dedicated to this because you put energy in that activity, and it psychologically is a good thing, but it could be wrong for the residual fibers which are still left in the cable, which are still useful after all.
In terms of things to avoid, people ask about specific issues like ADH medicines like Ritalin or Strattera. People ask about anti-anxiety medications such as Xanax, Prozac. Do you have any thoughts on those?
It's all anecdotal.
I must say that these certainly don't raise any alarm from my point of view, but possibly because I don't have that many patients who've raised this issue with me. But I don't feel that it should be a contraindication if it's indicated for other reasons.
It's a continuous scale. Most of these things we don't have evidence, and I'm always forced to tell patients the only reasonable thing I can say is when the studies have shown it. On the other hand, there's a few of them for which the theory sounds stronger than others. So as an example, I'm a little bit concerned about the amphetamines. The point of an amphetamine is to raise the metabolism, and raising the metabolism, even to the point of exercise perhaps, isn't in the extreme a good idea. So it comes into the classical situation that both the patient and his other doctors have to get into, which is how much risk and how much benefit. If you're taking Ritalin to lose weight, that doesn't sound like a good plan. On the other hand, if it's a key medication, and I've had many patients come to me saying, I'm on this medication, I have depression or something rather severe, and my doctor really wants me on it, then I certainly agree with Patrick that unless we have real evidence, we probably should not be disturbing what's good for them.
Yeah, there are very few medications with the proven interference with mitochondrial metabolism. So some of the antibiotics Alfredo was mentioning, that's definitely true. You should avoid those. And it's a short list of, after all, of medications. Then for epilepsy, valproic acid is known to be interfering quite clearly with mitochondrial oxidative phosphorylation system. So that would be something that if someone happens to have epilepsy overlapping with labors, maybe this is not the drug of choice for controlling the epileptic seizures. Statins is a big issue. Statins, I mean, patients with labors do not have a myopathy, but if you put them to exercise, they raise more lactic acid than normal people, because there is a slight impairment of oxidative phosphorylation, of mitochondrial function. So occasionally statins in predisposed people may actually do something bad to muscle. Could be overcome by co-administering, this is what we do in Italy, coenzyme Q, because one of the reasons for statins hitting the muscle is because it decreases, lowering the cholesterol also decreases the amount of coenzyme Q that is available to muscle. So if you co-administer coenzyme Q, this is just for muscle. It's not that you're curing the eye with coenzyme Q. I want to be very clear on that. It's counteracting the possible harmful effect of statins. That statins are very popular and very used, so we should take care of that. I don't know what's your opinion, Alfredo, on that.
Pretty close. And just when he says statins in the U.S., we usually pronounce them statins.
Okay.
But everybody knows we're talking about things like Crestor and Lipitor and so on. 30 million Americans take this. It's a very big thing. And the College of Cardiology just came out saying if a little's good, a lot is better. They actually want people to go up on their doses. So just to give an example, Lipitor, the standard dose used to be 10 milligrams. And then now it's 25, and many are going to 40. With the remarkable determination, with the statistics showing that not only does it make your cholesterol level goes down, but if you compare people on statins whose cholesterols are down with people who are down, they still live longer. So there seems to be a lot of benefit to statins that we don't want to get in the way of.
No.
That said, I'm also of the mind that maybe there is a sweet spot, a happy medium. So my personal recommendation, this is just common sense for me, this is not based on clinical evidence, is why don't you go ahead and take statins? You probably get enough benefit from what used to be considered ideal, the lower dose is 10 milligrams. Take the coenzyme Q10 for the reasons that Valerio has mentioned, but keep taking it.
And I agree. I think what we just discussed, all three of us, is basically a common sense approach of, what the person needs, right, to treat the problem at hand, and also the theoretical risk attached to the mitochondrial dysfunction. And very often, if one drug can be avoided and alternatively be used, that's the best case scenario.
Foods often get asked about, is there anything people can eat, should eat, anything they should avoid? Almonds come up. Anything in the world of foods that is helpful or not helpful?
Well, I think the story about almonds and some of these other nuts is because of this possible link with cyanide, and which might be mitochondrial toxic. And I must admit that personally I don't think it's a risk factor, because we do know that these nuts, for example, have a lot of possible health benefits, but everything is in moderation. So I would not tell my patients not to have almonds and other nuts products.
Fair enough. My approach, I try to be clever, is to say that's a quantitative problem. It's not a qualitative one. That is, a huge amount of cyanide can't be a good idea. But each almond has such a tiny amount of cyanide, you'd have to eat hundreds and hundreds with every meal to get into issues. Now, peach pits each peach pit is probably worth 100 almonds in terms of how much cyanide, so you probably shouldn't go on a peach pit diet. But really, it's just a question of degree. And maybe to that same point, I know that some people have approached me with the, is it called the aspartame? The blue packets of a sweetener. Aspartame, that's it. And I point out again that there's a reaction by which that can become something that could be something connected to what would be bad for you. The quantities are too tiny to worry about. So if somebody says avoid all arsenic, you'll never eat a meal again. Every meal has got a tiny bit of arsenic in it. It's just a matter of degree.
I want to add a comment and make a step back. When we do the blood workout of any mitochondrial patient, but definitely laborers as well, initially when the diagnosis is done, we always check for vitamin B12 and folic acid levels, because it's quite frequent that some people is down or on the lower side with that, and then we immediately supplement those, correct the deficiency. And so let's say that in general, any food with vitamins, it's good. I mean, vegetables and fruit probably it's good. And also, if there is any reason, clear-cut reason for having the vitamin deficiency, that should be also investigated and corrected.
I think Valerio wants to promote the Italian Mediterranean diet here.
Can we turn a little bit, you mentioned that there's much to be done in terms of protection and things not to do, and not much you can do proactively. But what can be done? Is there any therapeutic treatment that anyone utilizes that you'd like to talk about?
Well, let's start with the fact that I think that the bottom line to all of this is moderation. I forgot who used that magic term, but that seems to be a reasonable thing. I would suggest exercise, but not marathon running, and so on and so forth. And the antioxidant family of medications probably have some benefit, even though it hasn't been proven in this disease. But one, again, of the tricks to this is that one antioxidant in huge amounts is not nearly as good for you as lots of different types of antioxidants in small amounts. The fundamental problem here is that in the disease, you end up with this accumulation of electrons. They're spilled out of a particular reaction, which produce something called the reactive oxygen species. And so how are you going to get the electrons or the reactive oxygen species out of there? It's sort of a bucket brigade. Imagine a bunch of firemen each passing the bucket to the next one, getting it out of there. And what you really want in a bucket brigade is 10 strong firemen. Having 9 weak firemen and 1 super strong fireman doesn't really help. So when you hear that pomegranates are the best antioxidant, or blueberries are the best antioxidants, or any particular chemical, vitamin E is the best antioxidant, that's that super strong fireman in the middle of the line. Who's he going to pass it off to? But if you have lots of antioxidants in mixture, then it makes sense that you can move it out. And where do you get lots of antioxidants in mixture? I don't think you get it from the drugstore. I think you get it from every time you have fruits and vegetables, especially in a varied way.
Yeah.
Yes, absolutely. It's a part of the kind of healthy package that we're promoting: no smoking, fruits and veg, and just be sensible with everything, including moderation with heavy exercise.
And do you want to talk about idebenone at all?
Well, I tell you what, I'm going to pass idebenone to a man who's done both of these men have done a great deal with it. But before I get to that, we can talk about, has there been any proven benefit to a specific agent? And that's been tried. Vitamin C has been tried, vitamin E has been tried, and coenzyme Q has been tried. I think that they've been tried enough that we can say that, per se, they don't work, which is a particular disappointment with coenzyme Q10, because for the reasons that Valerio alluded to, it would make sense. And I think the conclusion was made some 25 years ago that vitamin Q10 is the right agent, but you can't get it in. So you can take all you want by mouth. It doesn't get into the mitochondria, so it doesn't really solve the problem. And so a version of coenzyme Q10 was developed in Japan, and it's called idebenone. It's a version that has the better drug delivery capability of getting in. And with that, I'll turn it over to you.
Yeah, I'll give you a historical perspective, and then I will pass the microphone to Patrick, because he was actually part of the clinical trial with the pharmaceutical company promoting this. So the historical perspective is that Idibenone was commercialized in Italy, so it was approved for being used in patients, and this is not true for other countries, for example, for in the United States, for dementia. So any kind of cognitive impairment, degeneration, and so on was told that could be treated with Idibenone as a neuroprotectant. And in early 90s, I guess was 92 or so, 94, whatever.
Around that time, the Mashima study.
Yeah, a doctor in Japan, Mashima, actually gave Idibenone because it's a similar molecule to coenzyme Q, but apparently with better distribution, better potency, gets into the mitochondria in a more efficient way. So he gave Idibenone to a patient with labors, and he published this little letter saying that the patient actually recovered quite a lot of vision. So because Idibenone was legally commercialized in Italy, we started giving Idibenone, and we also did study some of the biochemistry in vitro of Idibenone with cells. And so in Italy, has been possible to give Idibenone legally with no problems to patients. Then, at some point, a legislation came up in Italy protecting people with rare disorders. So each, under a specific certificate for diagnosis of a rare disorder, each patient has access for free to Idibenone. So this is being covered by the state. And at that point, we definitely started to administer Idibenone in a very systematic way to each single patient. So our patients' population, after a certain year ahead, they all have been given Idibenone as a therapy. So what we did at some point in conjunction with the clinical trial, and in a bit I will pass the mic to Patrick, is that we looked back at our patients after this certain year. We started giving Idibenone to everybody, and we compared the natural history of the patients treated with Idibenone with the natural history of the patients, of the relatives of these patients, which did not have Idibenone treatment. And on the very, I mean, the points, the two main points that the two main conclusions we had is that you have to give Idibenone for a long time, earlier is better, and in particular, the statistics was particularly solid with 11778. We raised the recovery, the rate of recovery from 20%, as I was mentioning before, spontaneous recovery, up to 40 or so. So what we see with Idibenone in our experience is that we never been able to stop the progression of the disease during the acute phase, not in a clear way. Maybe we can preserve some fibers during the acute phase, but it's a matter of fact that the patient would lose vision anyways. But what happens is you increase the capability, the probability of actually recovering vision later. And this is probably related to the fact that you are sparing more fibers during the degenerative process. If you have more fibers, even if they don't work, at some point you can reverse the process and make them work, and so then you recover a little bit of vision.
Excuse me, just so there's no misunderstanding, by recovery he doesn't mean full recovery. He means some modest improvement.
Some improvements, yeah. So,
I think it's been very helpful, Valerio, giving the historical backdrop, because as Alfredo mentioned, it all started with coenzyme Q10, which made a lot of sense, but one of the big reasons why it's probably not working is because it's quite a big molecule. It does not cross the blood-brain barrier very well and does not penetrate the mitochondria to provide its function. So now we have Idibenone. Alfredo is very lucky. Valerio is very lucky because in Italy he's been able to provide idebenone to his patients, covered by the National Health Service. But we don't have this opportunity in the UK. So about 6 years ago now, with my colleague Patrick Chinnery, who is a professor of neurology in Newcastle, we got involved with Santhera, the company based in Basel, who basically provided the resources to do a randomized controlled trial for idebenone. So it compared two groups of patients, patients with labors and who had the active medication. The dose of idebenone that was used was 900 milligrams, so 300 milligrams 3 times a day, and that was compared against placebo. So people who were taking dummy tablets, but they did not know whether they were on the active or inactive compound. The study was relatively short. The study was for 6 months because obviously there's a cost attached to doing any trial. And when the results were analyzed, the main outcome measure was negative. But then when we did a subgroup analysis, there was a group of patients who had earlier duration of the disease process who seemed to be doing better. And as Alfredo mentioned, we're not talking here about a dramatic recovery or reversal of vision, but statistically, if you compare the group that was treated with the group that wasn't treated, they did better. And again, our study was slightly undermined by the fact that it also included patients with the 14484 mutation, where there's a better visual prognosis. And as Valerio mentioned, the treatment effect was much more obvious when we did the subgroup of patients with the 11, 7, and 8 mutation. So what did we find after doing this randomized control? First of all, it's safe. There were no major side effects. It would be advisable if someone takes idebenone after 6 months to have their liver function checked, just to make sure there's no disturbance there. And based on the promising results from the subgroup analysis, Santhera then went to CHMP and EMA, which is the version of FDA here in the US, to get approval for idebenone for patients with Leber's optic neuropathy. So 2 years ago, they got the decision that EMA said no, because they felt there was not enough evidence based on the amount of patients that were treated and where the treatment effect was found. So that left us in a very difficult situation in the UK because patients obviously knew about idebenone, wanted to get access to it, but we could not prescribe it. In the meantime, Santhera has launched a named patient program, and I don't know the final numbers, but they certainly recruited more than 60 patients into this named patient program. A lot of patients were recruited from Germany, in Munich, by Thomas Klopstock. And my understanding from what has been in the public domain is that at the moment they've submitted all the data again to the EMA, and they're expecting a result in the next few months regarding whether or not idebenone can be prescribed to patients with Leber's optic neuropathy. So my personal feeling about idebenone is that it's not the magic bullet. It is certainly not the best treatment out there for Leber's. We need much better treatment for this condition. It seems to be having a positive effect, but we can't predict who is going to benefit from idebenone. The other question that we don't know is how long we need to treat, because the advantage that Valerio had is that his patients were on longer-term treatment, and when we look at your data, it seems that the longer you treat, the better the visual benefit between the treated and treated group. So I think there's a lot of unknown. My personal wish would be that whatever happens with Santhera's more recent application is that we need a bigger trial with more patients treated with for a longer duration of time, and also with higher dose of idebenone to clearly fully establish what is the effect of idebenone on the natural history of Leber's optic neuropathy.
Yeah, one point to emphasize, I'll be very quick, Alfredo, is if a Leber's patient gets idebenone and after 6 months doesn't perceive any apparent improvement or effect, it needs to keep going. This thing works on the long run. And in general, for any antioxidant approach, so I'm not talking just about idebenone, but possibly about other antioxidants, and we may mention this. The experience is that correcting the biochemistry of Leber's takes months or maybe years. It takes a long, long time in order to make this fibers getting back to function. So if you give up too early, actually you wasting the probability of having some good effect.
I completely agree, and I was about to make that same point, and also to tell you how I think of it. I think of it as when you have your vision loss in the affected patient, that typical patient I told you who was in his freshman year in college, you're losing all the small fibers and maybe some of the medium ones. And Idibinone probably doesn't have any benefit there. But its benefit is it keeps that advancing wave from affecting the medium-large ones and so on and so forth. So it's a good idea to have it, to keep taking it for a long time, forever. I never ask a patient to come off of it because it's working on that later phase of the advancing wave of the loss from one to the other. Also, I should mention, because my distinguished colleagues are from England and from Italy, here in the United States, we don't have a National Health Service that gives Idibinone free, but the majority of my patients go to the internet where it's quite available legally as a food supplement. It is not restricted by the FDA. And so we recommend that you actually look at several different internet sites for this, because not being FDA approved, it's a little bit less certain that they're going to stay open, so you want to make sure that you can get it and maybe stockpile it a little bit. But it has been sampled and analyzed, and at least the sites that we have been putting out there are the real thing, and they get the same Idibinone. Probably with a little bit less precision in terms of concentration, but since we don't know the exact concentration to give, I don't think that's a big deal. So if you end up getting 5% more or 5% less on the internet versus the prescribed amount, I think that's well within tolerable range.
And when patients do take this, is there anything they should do in addition to taking that?
Yes, and there's one thing they should do in subtraction. So first, the addition. Idibinone acts to prevent oxidation. And in itself, it gets oxidized in doing that. Now, some of the people here in the audience might remember, how do you prevent a cut apple from turning brown? That's getting oxidized. And the answer is you put some lemon juice on it, and then it stays nice and fresh for a day. Well, you do the same thing using, and the reason that works is that there's vitamin C in that lemon juice. You do the same thing to the person. So I don't think the vitamin C by itself is particularly useful, but it's a very good idea to give it in addition because it keeps the Idibinone in its reduced stage, in its fresh state. It's like putting that lemon juice in the apple. The flip side is there's something you should not take. We talked about how, in general, taking coenzyme Q10, if you're, say, on statins, is a very good idea, and I agree. But if you're going to be taking Idibinone, I would rather you did not take coenzyme Q10, because there's good reason to believe that the transport molecules, the mechanism by which your body pumps the Idibinone into the mitochondria, is the same as putting the coenzyme Q10. And now if you put the less effective as well as the effective medication in at the same time, the body in a sense gets distracted by the ineffective one. So I think that's the one time coenzyme Q10 may actually be a mistake.
Yeah, one comment is about dosage. There is no established dosage for this therapy. The company used 900 milligrams. What we do in Italy is in acute cases, we go up to this 900 milligrams, and we keep going until things are dynamic, which means until we observe some changes in visual function, we stay up. After 1 or so year, maybe 2, that nothing happens and the situation is completely stable, at that point we can also try to reduce a little bit the dosage, and usually we go down to 450, which in Italy would be, in Italy we have pills 45 milligrams, so everything is based on how many pills, and usually we do either 9 or 12 in a chronic administration. But during the acute phase, you want to go high. Some side effects. Idibinone is safe, but what we see sometimes is raising cholesterol in some people. So maybe we should take care of that, and diet at the same time as you get Idibinone would be an option. Before you get the statins. And sometimes in kids, in younger people, you can actually get some decrease of white blood cells, leukopenia. All these things are absolutely reversible, and they do not produce any symptom. These are just things that you see because you do the blood exams. And then we usually check that the person is able to have a normal renal and liver functions, obviously.
Yes. From the UK perspective, as people have mentioned, there is always an interrogation mark on what dose to use and how long to treat. And people in the UK who decide to go on idebenone will get it from various internet sources, very often based in the US. And the cost is not inconsequential, especially when you add import duties and everything on top of that. And sometimes, if people don't get any benefit from it after 6 months or a year, it's a bit difficult for them to motivate themselves to carry on paying for it. So I think the cost element should not be discarded altogether.
Of course. And it should be, speaking of the economy for idebenone, you probably do a better job absorbing it, therefore getting more bang for your buck, if you consume it with some sort of fats, because it's a fat-soluble molecule. So men don't usually need to be told to take some fats. You know, they're going to have French fries or milkshakes or hamburgers anyway. But we would explain to women that if you want to have a salad for lunch, maybe this is the time not to have it with a low-cal dressing. A little bit of fat will help the idebenone go down.
And Dr. Yu-Wai-Man mentioned that sometimes people will choose to stop taking it for various reasons, economic, whatever. Should they just stop cold turkey, one day take it at 900 milligrams and one day stop, or should they taper down? Or
My experience certainly is people will make their own decision, and people will come back for their follow-up clinic appointments. They will have told you that they've stopped it altogether, or they've gradually reduced it, or they've run out of it. So it's a bit of a difficult situation at the moment. I think we need more clarification, certainly from the EMA, about what is going to be the long-term status for idebenone.
so, are there any treatments that people should avoid doing? You've sort of told us that there's nothing that's a magic bullet, but everyone's looking for it. And a lot of patients look around and find things like hyperbaric oxygen treatment or stem cell therapy, infrared LED. There's talk of a variety of treatments out there. Is that something people should consider or avoid, and why?
I'll speak to the first two items that you mentioned. In regards to hyperbaric oxygen, please don't do that. That's a good way of making things worse. There's no lack of oxygen in the metabolism of a patient who has labors. On the contrary, there's these reactive oxygen species that we've been talking about. The point of idebenone is to take away the reactive oxygen species. They come from oxygen. Taking more oxygen is aggravating the situation. There are anecdotal stories of individuals who've lost vision in one eye, and we know they're going to lose it anyway in the other eye, but that they lost it the day after hyperbaric treatment. In regards to stem cell therapies, for the moment, I hope that this will change in the future, but for the moment, they're a scam. In this particular issue for the optic nerve. They're available in rinky-dink little hospitals in Western China and Northern India, and one was available in East Germany, which finally got closed down. The idea that they can inject into your spinal cord your own stem cells wouldn't answer the problem anyway, because you need them in the eye, not in the spinal cord or the brain where the spinal cord circulates. It's just $50,000 out of your pocket because they're trying to get your $50,000. Better that $50,000 should go to this organization where it will lead to real advances. I think that there are some therapies on the horizon. I don't know if you want to get into them now or later, but later than it is. I remain hopeful.
Yeah, and no laser surgery, no these weird things that sometimes happens. I had cases being operated for vitalizing the optic nerve through lasers. There is not such a thing.
I've not heard of that one.
Oh, speaking of weird therapies, one other that I forgot to mention, and that is red light, LED lights at 680 wavelength. The idea is that at that wavelength, the system called oxidative phosphorylation of the mitochondria is stimulated and works overtime, and it does. And there's some diseases for which that might actually make sense. For example, healing scarring after injury, where you want to rev up the mitochondria. But that's the opposite of what we want to do. Revving things up means more reactive oxygen species are being spilled. So Valerio and I, on our yearly trips down to Brazil, where we have several hundred carriers there that we've been observing, thought to use that, had the person who had developed the technique come down and join us. But as we discussed it, we got scared and realized they could make things worse rather than better. So we did it in a very limited trial in people who were the most profoundly blind and essentially had nothing or very little to lose. And we did it in one eye only, and we measured. And what we measured was people saying, I think it made me better. And that points out, again, to what we all know, the power of the placebo effect, because when we made the measurements, they got worse. So we didn't do the trial. And so I'm also saying to you that in a small, limited number of patients, I think we had 6 of them, it was dangerous, and I don't think it's a good idea.
Can we talk a little bit about follow-up care? So specifically vision care. So somebody's been diagnosed. What follow-up care should they have for their vision? Who should they see? What testing should be done?
Well,
You start?
this will certainly vary depending on where you are in the world. In the UK, I would normally review the patients every 3 monthly in the acute stage, and then they would normally come in the chronic stage on a yearly basis. They're getting it free on the National Health Service, but eventually quite a few people come from outside the region, have to travel. If they have a good local optometrist, will be seen there and have their vision checked on a yearly basis. So they absolutely need to have a check done at least once a year. Who does it and where depends on the practicalities.
Well, we see patients every 3 months during the acute phase, unless the patient is enrolled in a specific study. And I have the fortune to work with the ophthalmologist Piero Barboni, who has been very instrumental in studying using these fancy last generation machines like OCT, the very initial stages and describing what is happening in the eye. But unless you're part of a scientific program, we follow every 3 months in the acute stage the patients. And then, as Patrick said, once a year in the chronic phase. I think the patient needs to be seen once a year from an experienced person with labors, which should be communicating with the local ophthalmologist in a very productive and friendly way, and because some of the exams that could be useful can be just done locally. You don't need to travel far away to make a visual field or something like that. But once a year, all the data should be wrapped by an experienced person in labors, because the interpretation of what's going on sometimes is not that obvious.
I completely agree. In the beginning, when I'm seeing the patient quite often in the United States, we have a very big country. These patients are traveling great distances, and we try to do what you suggested, which is coordinate with somebody who is more local but has less experience with the disease. And one of the ways that we found that coordination to be most effective is by having the person in New York or Chicago, each time he sees him, sending me 2 particular tests. We mentioned that visual acuity is what everybody cares about, but probably is the most misleading test for this disease. Probably the 2 most useful tests are one for structure, how many axons are there, and that's the OCT he was referring to. So you can use that to do what's called retinal nerve fiber layer analysis, which basically says how many axons are left.
And now the ganglion cells in the macula.
Yeah, which not everybody does, so it's not ready for
very
it
soon
will
it
come.
will come.
And a Humphrey visual field. That's a standardized way of doing it. If anybody's taking notes, the 30-2, because that's not a standard way of doing it. And so the ophthalmologist in Toledo will do these tests and see the patient perhaps every 3 months an eye, every 6, or later on, every 6 months an eye, every year, and send me those tests for comparison. These are standardized machines, which means that we can compare the notes from one place to another very effectively.
And should somebody see someone like this yearly from age 20 all the way to the end of time? Because I think there's sort of, a perception of, I've had this vision loss, what's more to be followed? What's the point?
Yeah. I mean, I have a hard time persuading people for the reasons that you mentioned. But I do agree with Dr. Carelli. I think that having, if not every year, later in the chronic course, perhaps they can alternate, and alternation is what we usually do, where they see their own ophthalmologist once and then see me another, and therefore me every 2 years. But it's a good way of making sure that as we get new developments, this antibiotic we've just discovered is really bad, or this combination of vitamins you shouldn't take because it competes with this enzyme, they can get that information. And at the same time, sometimes it's not apparent to the patient. If they were to get better, and this happens, by 1% a day, that would still be imperceptible. Who can tell 1 part in 100? But on the other hand, if I see them in 100 days, I see a big change. So that if there's a trend up or down, we can pick it up, and it might be an important thing to understand.
Well, there is, I want to emphasize one thing. There is still a profound need for research to describe the natural history of this disease. So we only can run trial meaningfully if we know what is happening to the patient over the time naturally. And I think we still need to accumulate data on how the disease evolves, because in the old days, the ophthalmologist, once the acute phase was finished, would say, okay, there is nothing that we can do, you lost vision, that's the end of it. No, we need to follow the patients every year and to know exactly what's the evolution of this disease. So the so-called natural history is an essential information for then running trials in a meaningful way and designing the trials in a meaningful way.
And I completely agree, because that's the point I was going to mention, Valerio, that essentially there's the need to accumulate this data about the natural history. And we're also hoping that in the years to come, with all these potential new studies and trials starting, that people will be involved and will be monitored in the long term to study the effect of the treatment. So hopefully this will not become a major problem in terms of motivating people to come back.
Yeah, having the combination of a registry, so having the knowledge that there is a certain amount of patients out there which has been followed and characterized very precisely, is again the basis for running trials later on. So,
and a final point, which is that we said it's a complicated disease that most ophthalmologists don't fully understand because they've never seen it. Just to be clear here, the average ophthalmologist in the United States, how many times do they see a case of Leber's in their lifetime? 0. So they're really not going to be comfortable. Well, you think the diagnosis is made, the treatment's given, what does it matter at this point? Well, there are other diseases of the eye. Glaucoma is the most likely to be confused. And now that he has said, oh, I understand, I've learned it's Leber's, he still doesn't know exactly the pattern that can be ascribed to Leber's versus the pattern of macular degeneration or glaucoma. So especially as we're getting into later years of beyond middle age, and these diseases do creep up with great frequency, it would be very helpful to have at least once every 2 years a neuro-ophthalmologist saying, that visual field defect that has occurred is not the one we see in Leber's. Something else is going on.
correct. Yeah.
And so now turning the tables a little bit, vision care is really important, but when a person's diagnosed, what should they tell their other healthcare providers? Should they talk to their primary care doctor, and what should they say? Any other healthcare providers that should be informed, and what information should they transmit? Because that group is going to know even less than the ophthalmologists.
And as you rightly mentioned, communication is key, and certainly if you see a patient with newly diagnosed Leber's optic neuropathy in clinic, the first thing is certainly in the UK, is that you will register the patient as being partially sighted or severely sight impaired, and that will set into place a long list of communication involving the general practitioner, the family doctor, social services, and occupational rehabilitation. So this system has its advantages because it puts all these social net together, which, let's face it, doctors are very busy, they don't have the time to do that. And also at the same time, practically, I have a very good low visual aid liaison officer working in clinic who can help with setting the link with these various support services, which, although we want better treatment, I think the basic also need to be looked after quite well. And also, there must be proper access to low visual aid clinics in terms of magnifying aids, visual aids, and also for young children who are still at school, you also need to have the liaison with the educational services in terms of the help they need, because there's no reason why they can't be kept in mainstream schooling, but they will need the support.
Communication is very useful. There are a couple of particulars that come up with some patients and not others. For example, as many people in the audience know, there may be in some of these labors itself and other mitochondrial optic neuropathies some issues of hearing. So in those cases, we obviously want an audiologist involved. There may be issues having to do with a neurological condition for which a neurologist is helpful, or cardiac condition for which a cardiologist is helpful. So as needed, this is obviously on a case-by-case basis, coordination. I've, in my experience, had excellent rapport, and again, most of these doctors don't have any experience with labors and are very happy and willing to work with us. The only pushback I've gotten with a little bit of regularity is from OBGYN. And it usually is not the patient who has lost vision that is the issue. It's usually his mother, to which I say, I really would like you to not go through menopause, because that is a second risk period. And I provide a note or an explanation which is brought back to the OBGYN, who says, it's not my policy to give hormone replacement therapy. And then usually I come back and says, yes, but 15 years ago it was your policy to give everybody hormone replacement therapy. I know that the pendulum swings and the fashion has gone from every woman should be given estrogens to, oh, well, that can reduce strokes and heart attacks and none can. And my argument usually goes, let's customize it. Let's understand that even back then, it would have been a very bad idea to give estrogen to somebody who has the BRCA mutation for breast cancer, because that's just begging for trouble. Here we've got sort of the flip side. We have another mutation that makes estrogen a particularly useful adjunct. So rather than just look at that large population, let's focus on this population and recognize that in the risk-benefit analysis, there might be some value to it. And usually by the time we get to that part of the conversation, the OBGYN recognizes the situation and says, well, which one should she go on? And I say, well, that's where you're the expert.
So would it be reasonable in the U.S. to give the primary care doctor the avoid list, the list of items to avoid? Should they share that so that they don't get prescribed the antibiotics that are on that avoid list?
I haven't, and you're giving me pause to think that maybe I should. But one thing about the avoid list is that it's probably not so dangerous to go on it for a short period of time. The person who ends up with a week of antibiotics because of a bad toothache is not the concern I have. The one who goes on it for a long period of time. So there's plenty of time for that communication. And in the end, especially in the United States, and I'm not really sure how things are in Italy and in England, but I do know, for example, it's different in places in South America and Asia. But in the United States, it's understood that the patient is his own advocate. And I trust the patient most of all if he has a list to tell the doctor, listen, you put me on something on this list, what do you think we should do?
And you talked about the long-term use of the antibiotics. That a lot of times teenagers being affected and acne, that comes into play, dermatologists. Is that something to discuss with a dermatologist?
Usually the antibiotics that the dermatologist chooses, at the doses they choose, I don't think are an issue.
Yeah,
And I had this discussion recently with dermatologists, and very often they will have alternatives like more topical treatment, so I don't think this will prevent the teenager from dealing with the pimples in parallel.
yeah, in general, a good relationship with all the other specialties, doctors, and with the family doctor is important, and we do this in Italy. Maybe the idea of having not a list, but a standardized recommendations for doctors for most of the things that we discussed up to now could be an idea, and could be actually elaborated through UMDF or through the patients' organizations in some ways.
This conversation, and this isn't the first time this has happened, from Melissa, has inspired me. I think we should put together maybe a 2 or 3 page pamphlet,
something
really
simple,
that says how does having labors affect the other medical decision making, and such a document might be very helpful.
Exactly. Yeah.
Sounds good. Some miscellaneous issues that come up from time to time. Some patients talk about getting red flashes, white flashes, pixelated colors. Have you heard that from patients, and can you explain what's happening?
Yes, certainly a lot of patients will report these positive visual phenomena, and actually the story about the exercise, I had a patient recently who mentioned having these very funny flashing lights and colored lights after bouts of heavy exercise. So essentially, as Valerio and Alfredo mentioned, we're dealing with an optic nerve which has been damaged here, and these retinal ganglions that are still left, some of them are not working at full capacity. So conceptually, if there's something else which is stressing it, whether it's an illness, whether they've been exercising very heavily, that could induce these signals to be transmitted the wrong way and therefore produce these positive phenomena.
Right. Positive visual phenomena are largely due to imbalances. Those 1.2 million fibers work in interesting balances. As a matter of fact, half the fibers tell you a light is on, half the fibers tell you the light has gone off. They're on fibers and off fibers. A lot of them says this is red, a lot say this is blue, and these that say this is green. None of them, by the way, say this is white. So how is it possible that when you're looking up here, you see me holding up a piece of white paper? It's because your brain has seen the balance that the red, the blue, and the green are in exact proportion, and that adds up to white. Well, supposing that the reds were out of whack, you would see this as the opposite, purple. So anytime that there is an imbalance, there's a tendency to misappreciate, misperceive, and that's where these positive visual phenomena come in.
Yeah, I want to add a couple of things. So these phenomena frequently are happening when you lose vision, but, and this is a observation that has no proof, but it's anecdotal, but it's something that happened to me frequently. This phenomenon also preceded the recovery of vision. And as Alfredo said, when you have an unbalanced way of transmitting this signal through the nerve, through the fibers in this cable, this is the result. So I have a personal theory that some of the fibers are not correctly wrapped by myelin, which is like a plastic wrapping to isolate the single fibers. If this myelin is partially destroyed by the disease and is reconstructed, because this is happening, at that point the fiber is able to fire again the signal. So the period where you have this dynamic process of restarting signaling through some of the almost dead fibers and getting them back to function, it's probably generating this sort of positive symptoms that are recognized. So not necessarily this is a bad, is a negative symptom. Actually, it could be interpreted in some cases as preceding the recovery of vision. What we don't know is also how much plasticity in the cortex is actually happening, and this is something that should be studied seriously with a well-organized research program with functional MRI, because obviously the brain gets less signal, but the cells can be reorganized in ways of maximizing the signal is getting, and so the plasticity of the brain is something that we don't know yet. Do you have any?
Yeah, absolutely.
And how about, some people talk about having hallucinations or Charles Bonnet symptoms. Can you talk about that too?
Yeah.
Charles Bonnet syndrome comes about from any cause of blindness from both eyes. So the brain needs to get a signal, expects a signal. And the easiest way to understand Charles Bonnet syndrome is if you're over 60 years old, you may remember there used to be telephones with a little dial that could change the volume on it. Or imagine even a modern telephone, a cell phone, that you can change the volume. And what would happen if you started going deaf? You'd keep pushing that get louder dial until you'd finally be picking it up to such an extent that you'd be getting static. Well, that's what Charles Bonnet syndrome is. So the brain keeps saying louder, 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 and amplifies the signal to where things that aren't even part of the signal, noise, gets picked up. But in the brain, noise isn't like a little lightning bolt. That sort of static isn't the case. It can be incredibly clear visual images. And typically they involve sharp images of little animals or colored. So imagine if you saw a little pink elephant, you'd say, I'm going crazy. No, that could be Charles Bonnet syndrome from any cause of vision loss bilaterally, including Leber's. So it's awfully important to know that it is not a new problem. It's not the brain malfunctioning. It's just the brain that's starved for information. And typically the brain figures this out in time. And the majority of patients who see images will stop seeing it after a few months.
Some patients report sleep issues.
In general, there are sleep issues associated with blindness. Fortunately, in the case of labors, the most important fibers that regulate what is day and what is night, the ones that are telling me right now you're jet lagged because I'm out of whack with where I am, those fibers are generally spared in labors. And so the majority of labors patients don't have those. Now, there's a separate issue altogether, which is that anybody who's undergone any injury of any significance is apt to get some grief and depression over it, and that can interfere with sleep. But there is a sleep problem associated with blindness, and unfortunately they've given it already a name. Why is it we never give names to these diseases? It's obviously some commercial product that does. I think it's called non-24. You've seen it on TV. But that, while it does occur with blindness, is pretty unlikely to occur in labors.
Yeah, well, the good news is that, as Alfredo mentioned, these little receptors, which are ganglion cells, are in the same category of cells which are affected by labors, for some reason are actually spared. So the eye is still able to tell the brain if you have light or you have darkness. So the circadian rhythms, all the rhythms of how you produce hormones or the temperature goes ups and down over the day are completely maintained, and sleep is part of this circadian business. So from that point of view, I don't see, fortunately enough, any real physiological or physiopathological basis for sleep disorder. Idibenone sometimes, in some occasions, because it's an activator of the brain, gave problems in actually falling asleep in some patients. So what I do in those particular cases is just shifting the dose during the day and not giving too much dosage at the night, for night.
You know, Valerio, I have seen patients with problems with circadian rhythm, and they've usually been patients in their late 50s, 60s, and 70s whose vision is down to hand motion. So extremely advanced labors, which is one more reason for those who say, oh, I've already lost my vision. It doesn't matter now. I can smoke all I want and now take care of themselves, is a very bad idea. You don't want to get to that very advanced stage. Because I think the disease has, looking at it from your point of view, you're doing fine, you sort of have a lot of loss, but it continues out there. And you don't want that. You don't want, if you've left to lose the small fibers, that's a great shame. But let's save the medium ones, and for goodness sake, save those big ones, and these are called melanopsin guys, because losing your circadian rhythm is a big deal, and you wouldn't want to be in that situation.
So what I'd like to do now is open it to the floor. We have 2 microphones available. And I want to remind you that right now we're just focused on affected men with a 11778 mutation. We're going to come back and talk about other mutations. We're going to talk about carriers. We're going to talk about the research. So all that will come later. But if there's anything that we didn't pick up in this discussion about a typical affected male, this is your chance. Raise your hands. Microphone's coming around.
It's always hard to get into the first one, right? Once one comes to the microphone, 20 will follow.
I have Labor's Plus, which is neuropathy also.
And I'm going to stop you right there. Labor's Plus is going to come later. So if your question's about plus,
this is about the ad. So I saw a mitochondrial neurologist recently, and I know myself, and I talked to a few people, are on the 900 milligrams of idebenone, and she told me that that was a low dose, and we should take more. Is that true, or?
Well, we don't really know the answer about what dose is optimal for patients with Leber's optic neuropathy, and also for those patients who are unfortunate to have these LHON plus features. I suspect what your neurologist was referring to is the fact that idebenone has been used in other trials, for example, in Friedreich's ataxia, where they were using a much higher dose, 2,250 milligram per day, as opposed to 900 milligram per day for Leber's optic neuropathy. But as to whether one dose is higher and therefore better and you should be on it, I don't think there is an answer. It's not evidence-based.
I think it's important to understand that one size does not fit all. I think that he's thinking, in terms of Labor's Plus, of a much more general category of mitochondrial disease. And so we do have a hard time knowing what is the right dose. But as was alluded to earlier by Dr. Carelli, in different situations we give different doses anyway. And so I have patients as low as 450 a day, many on 900, and a couple of patients who get more. It depends.
Hi, I've got three very quick questions, if I can try and get through them quickly, and you can choose which to answer, whether all of them or for whomever. Regarding taking CoQ10 with statins, I'm curious, given what we know about the poor bioavailability of CoQ10, why you wouldn't recommend taking idebenone with statins rather than CoQ10 for unaffected carriers, for example. On the stem cell therapy, these trials or programs are not just happening in the Wild East, but also actually happening today in Miami, where there is a clinical trial taking place, a so-called clinical trial. It may be that you don't feel able to comment on that, and I understand and respect that. But these things, of course, are much more credible than something that takes place in central China, where it is supposedly unregulated. And then finally, Dr. Carelli, you mentioned that you were typically seeing a 20% spontaneous recovery for the 11, 778 or 3460. And that still seems astonishingly high, I suspect, for most people in this room, because that essentially means that 1 in 5 of your patients is seeing some recovery with or without idebenone and possibly stepping up with. So I wonder if you could comment on that, what seems to be a very high rate. Thank you.
Yeah, well, these are the numbers that has been generated by reanalyzing the patients. I know that in the literature you go as low as 4%, and I think Nancy Newman documented this 4% a long time ago, and you go up to pretty much around what I say, around 20%. The point is maybe we should clarify what we consider visual recovery, and that could be debatable actually. I tend and I try to sharply distinguish the adaptation I was mentioning before from what is really a recovery. And the classical definition of recovery done by Eva Nikoskelainen in the old days was gaining 2 lines or so.
Which is modest improvement.
It's a modest improvement. So maybe, as I said, in the US, people is not being followed so strictly after the acute phase, and you cannot document properly how much of this slight gain you have. So we cannot rely on the gut feeling of how many of the people with labors you know did the recovery or not. Statistics is based on a systematic study. So based on our numbers, I have that result.
And it goes back to what you mentioned, Valerio, about the need to have these larger data sets to be able to understand this. Because you're right, if you look at the literature, whether it's from Eva Nikoskelainen, from Anita Harding in London, or Nancy Newman, the range varies from 4 to 15%, but they have different criteria. And it's absolutely critical, as you know, Russell, because in terms of, if someone else says that the treatment is helping 40% of patients, what do we compare it with, right?
Sliding scale, I agree. When I saw your 20% numbers, and you brought it to my attention before the publication, I was very surprised, as this gentleman was, saying, wow, I don't think my patients do that well. But yes, the numbers are accurate, but if we keep in mind 2 lines of vision could easily escape the patient's notice. Because they didn't get the 2 lines between Monday and Tuesday. They probably got it over a period of a year, and those small increments were not noticed. I'd like to take a stab at your first question. I'm hoping we can address all 3 of your questions. They were excellent. And regarding the use of idebenone, perhaps in patients who are either carriers or on statins, so in any case we might consider to be at risk, I see the logic. I certainly take your point. I am still nervous about going to a medication that not only is not FDA approved, but more importantly, their experience is rather limited with it. And we've had a number of circumstances where people were given medications that looked to be quite innocuous in the small number of patients that they were first published in, only to discover that some really unexpected bad things developed. Thalidomide would be obviously a dramatic example, but other things as well, 10, 20, 30 years down the line. So I'm uncomfortable, but might change my mind in a short time.
And I agree with Alfredo, although we've all been kind of talking about idebenone being safe, showing promise, there are also other people out there, biochemists, who argue that actually there is evidence that the idebenone, depending on the balance of these metabolites further downstream in the redox state, they might actually be not beneficial, but actually counterproductive when it comes to your mitochondria. So perhaps Valerio will have some comments on this.
Yeah, well, any antioxidant is a sort of a double face, and it could act as a pro-oxidant, and really depends
Think
on
of the bucket brigade. If
Yeah.
it's a reducer to the guy to your left, it's an oxidant to the guy to your right.
So you should be very careful in judging what's the environmental situation where the drug is acting within the mitochondria in different situations. I would say also this, before we get to the population of carriers with some proposals, because there are other options. I'm personally, for example, in big favor of using drugs upregulating the natural compensatory response that carriers have, which is generating more mitochondrial biogenesis. We also need to do these things in an organized way. If at some point we will be giving some drug to carriers in order to check things, it should be done in a scientifically organized trial and not just here and there individually. Besides the fact that it's personal responsibility of each individual to be free of doing what he wants. So definitely, as doctors, we cannot, if someone wants to get vitamins or even the adibenone, we cannot say no. But in order to have a meaningful result from an experience in carriers, we have to think about it, and we need to be very careful until we don't understand exactly what we're doing.
But playing devil's advocate, this would be quite a difficult state to do, because you'll think about taking a group of patients who are asymptomatic carriers, providing a treatment, how long the study will have to be, and I'm just kind of...
And what are you looking for?
practicalities and
Are you going to look for whether their grandchildren have defects? I mean, you just don't know what the extended possibility of consequences are. So in general, you'll find us to be conservative until a lot of people have been on a medication for many decades.
Something that needs to be done and is very useful is actually to follow the carriers from the ophthalmological point of view, because we now have quite a lot of experience and technical means to predict or to at least suspect if the storms is arriving. So we have measures with OCT which are very useful and other stuff. Yeah.
And I'm going to ask you to hold off on the carriers and just stay with the affected a little bit longer. And were there any other questions in the audience about affected 1178? There are many. One's over here. Sorry.
Hi, my son is 15 and was diagnosed last year. My question is, he seems to get tired and he puts his head down in class. He also complains a little bit about his eyes feeling sore. I was wondering if that was common.
That's easy. No, not common, not even terribly associated. I mean, it's not in the eyes. The problem is in the optic nerves, and the optic nerve doesn't have reference to how the eye feels. So with this and many other optic nerve diseases, patients will sometimes tell me, but the eye is irritated. And I say, nah, that's not connected to that, except in one extremely indirect sense. Whenever a person has difficulty seeing for any reason, one of the things that the body does to compensate is to hold the eyelids wide open and to avoid blinking. And if you do that in a dry climate, and I don't know where you're from, enough time, then the eyes sort of get tired because they're dried out. So I have had a few people for a variety of reasons of loss of vision who I say, the nerves shouldn't make your eyes feel irritated. Try taking artificial tears over the counter, and many times with great success. If you're in a dry climate, maybe that's the story. Well, you might call it eye strain. I don't know what that means. I'll call it dry eyes. But we might be talking about the same thing. But Leber's doesn't irritate the eyes.
Hi. You spoke about the typical young adult male patient and some about menopause, but for the patients that are outside that typical age range, do you see different triggers? Are they similar?
We're going to come to that in a minute, if you don't mind. We're going to go to the different ages. So, sorry, hold that thought. Good question.
There is the gentleman here that is holding the, here. Yeah, that's you.
Sorry.
Here.
No, I was going to say, I don't even need a mic. I can't see anything anyways. All right. I had read an article about gabapentin regrowing the myelin sheath on nerves throughout the body over an 18-month course. Is that anything that you've seen having any results at all, or is that hogwash?
Neither. It does. I mean, myelin grows back if you give enough time or healthy circumstances. And I do agree with Dr. Carelli that's part of the natural healing process, and maybe the explanation for why spontaneous recoveries occur a year or two later, or why with idebenone sometimes you get improvements even 2-3 years later. That said, I don't think that it's the primary problem. There are other diseases like MS where it is the primary problem. So just providing stimulant for myelin growth, I don't think is part of the answer in Leber's.
Next question. Patty, you've got several right in the front here.
I've noticed, and I've did a little research, I'm finding that sometimes there's gastrointestinal problems and things that come along with not just LHON, but also mitochondrial disorders themselves. I know you all spoke of the hearing and the cardiac problems as well. Just wondering, I know my son has experienced some of the cardiac problems and things, gastrointestinal problems, but is there any other types of effects or things that we should be aware of that could have a major effect on the body? And is it only during a certain phase through the actual disorder, or is it long-term throughout?
Well, yesterday we were commenting with Lisa. So cardiac problems in the case of Leber's is those very occasional cases where you have conduction problems, so atrioventricular blocks or Wolff-Parkinson-White, so something related to conduction of the impulse, which could also manifest without optic neuropathy. It could be a separated issue. But if you come to ischemic cardiac problems, this is totally unrelated, or mitralic valve prolapse, this is totally unrelated to Leber. So please, we need to be very strict in actually, would you say parsing, separating?
Excellent word.
What is meaningfully related to a mitochondrial DNA mutation from what is actually something that could hit anybody, me or any other person into the general population.
And I agree. I think being able to distinguish whether it's just coincidental or whether it's an increased risk of another neurological problem is difficult. For example, people in the audience will have read about this link between the Leber's mutations and multiple sclerosis. And there has been some papers published out there which say that actually the Leber's mutation increases your risk of developing MS, but actually more recent work done in Newcastle suggests that you don't have an increased risk of developing MS. What it does, it triggers the process that would have given you MS otherwise. So it's a difficult question to answer because Leber's in itself is a relatively rare disease. Patients with these LHON plus features are a rarer subgroup of the bigger whole, and therefore how do you make this causal relationship between a possible factor and a possible clinical feature?
Thank you. I had two questions regarding drivers or triggers for the vision loss. One, have you seen any correlation between heavy exposure to the sun, say if the individual was a lifeguard for the summer? And my second, you mentioned, again, with triggers, have you seen any correlation between dermatologists prescribed drugs such as Accutane that many teenagers get prescribed around that time?
Well, to this first issue, I think, let me, in fact, take a step back. In most patients whom I see who have problems in neuro-ophthalmology, they think there's a trigger. And more often than not, the patient's mistaken. It's just human psychology. So I'm always brought back to the first time how badly fooled I was a person who fell off a ladder from the second step from the bottom and developed a very serious brain problem. And of course, when we did the scan, there was a tumor that caused it. But we always want to say, oh, it must have been this event because I bumped my head, I did this, I did that. And so I'm very skeptical in general. To the issue of your sunlight, I'm particularly skeptical because we've asked this question as to whether there are parts of the world that people are more likely or less likely to have it. And more or less worldwide, it's about the same. And even in certain families that were very carefully studied from England that moved to Australia, and I can assure you they got a lot more sun in Australia than they got when they were in England, they did not have a higher rate of being affected. So I just don't think that that is a trigger. In regards Accutane, Accutane is given to a tremendous number of teenage boys, and teenage boys are the ones who are at risk for this disease. I think that either all of them or at least the vast majority of them, it's a coincidence.
Regarding Idebenone, what recommendation would you have for an affected patient in their 40s or 50s who has never had been taking Idebenone or had any real recovery or reversal?
Yeah, this is an extremely good question. My feeling and what I do is to make a try with any patient, because the theory here is that you have a certain amount of fibers left and a certain subgroup of these fibers is suffering and not functioning properly. So this tiny group of fibers could actually benefit of Idebenone, even in a very long chronic patients that has had the disease for decades. I would make a try. Then after a reasonable time, let's say a couple of years, nothing happens, everything is stable, you can always drop the administration of Idebenone. But in general, I would make a try because there is always a certain amount of fibers that could be ameliorated, rescued, protected by Idebenone administration. I don't know about you guys.
I agree, but it's always a risk versus benefit comparison, right? And so you heard me earlier saying I wouldn't give Idebenone to carriers because I think the benefit is greater in a middle-aged man who still has this wave slowly marching from small to medium large, and I'd like to stop it wherever it is.
Let me just jump in for a minute, and somebody started to ask a question, which is actually the next one I had on my list, so we'll get to that same question. Let's turn for a moment to a late onset LHON affected. Let's talk about a male over 25, 11778 mutation. Is there anything different about those patients systematically than the more typical?
A race to speak first?
Please, my good friend can go first.
So, we started from a completely anecdotal observation with this family in Brazil. And then we reanalyzed all the data that we had from the Italian patients, and actually they probably fit with the UK group of patients as well. The impression is, obviously, it's not always black and white. So if you subdivide patients by being exposed to some environmental factors triggering the disease. And let's say, just for simplicity, just consider tobacco. So if you subdivide patients between those who smoke tobacco and those who did not smoke tobacco at the time they got affected, so they lost vision, then you have two very precise subpopulations. So people not being exposed to the environmental trigger usually have an early onset disease and quite severe. Let's say this would be the classical case at 15 to 20 years of age with the profound loss of vision and so on. Then you have this subgroup of patients that are exposed to tobacco. The average age of onset is actually shifted quite a lot. So in this group of patients, you would have an age of onset which is over 30. And a subgroup of the subgroup is actually over 40. So over 40 years of age onset seems to be people that were exposed for decades to tobacco smoking. If they were not exposed, they probably would stay carriers, not being affected. So I start seeing in our data a sort of division between purely genetic cases and the purely environmental cases. And the purely environmental cases are sort of different in clinical expression characteristics and so on. He has some experience because they ran a specific study on all cases.
Yeah, we discussed that, Valerio, quite a lot, and it makes sense that, you have your classical disease where the genetic factor predominate, but as you grow older, then the environmental factors become more prominent. The caveat I would say to that, and I see René Decoux here sitting in the audience, we did this big study, as you know, involving the UK families, German families, and the Dutch families, looking at risk factors from which the smoking story came out. But the paper was published last year, but we also looked at a subgroup of patients, about 20 or so, with visual loss greater than the age of 50, so late onset. And when you did the statistical analysis, right, there was no real obvious distinguishing factor between the smokers and non-smokers. So I think there is good, certainly your data is very convincing, but I must say that when we looked at our subgroup of late onset in these 3 geographical areas, that story did not emerge.
Yeah, I know because I did review that paper.
We've discussed this so many times that we tend to get maybe a little bit into the weeds here. I just want to bring it back so everybody understands what we're talking about. Essentially, that labors can be on a hair trigger, and that tend to happen usually in the teenage boy. And it's just so set to go that it doesn't need anything to push it over. Or it can be in a situation where it has a chance that the patient will never lose vision, but if you accumulate enough stresses, enough triggers, it'll happen anyway. So the first group we can call the typical group, and the second one, for the purposes of this discussion, we can call it atypical. But unfortunately, the vision loss can be just as bad on the one that's not on a hair trigger. But it's all the more incumbent of us to try to avoid those risk factors and to perhaps mitigate them with things like adibinone, because there are some patients for whom it's not fated to lose vision.
And I think what has become so clear, isn't it, compared to what we were discussing 10 years ago, is the role of environmental factors in how we, and it's really relevant in terms of what we're going to discuss later on this afternoon about understanding about the genetics. We've been so obsessed by genetics for a long time that this has actually muddied the water in terms of analysis, and now we need to take these into consideration.
Yeah.
And then on the flip side, early onset patients, anything different about an early onset patient?
Oh, yes. If you have to lose vision, lose it at age 5. Might sound like a very counterintuitive thing, but it turns out that kids who can lose vision profoundly from labors can also regain it back. Not only is spontaneous recovery possible, it's the rule there, not the exception.
And putting into frame this little subgroup, a very precise subgroup of childhood cases, in the frame of what we were saying before, these are obviously pure genetic cases. So that subgroup of patients is very important from the research point of view, because they should reveal something from the genetical standpoint very clearly, because they are obviously not exposed to tobacco.
We haven't met yet the 5-year-old who's a chain smoker.
Exactly.
And people often ask about idebenone for children. What words get said?
I did give idebenone in a few cases to childhood cases, and they seem to do well. They do well anyways.
Yes, but I think that idebenone makes them do even better.
At the same dose as an adult, maybe less, maybe they talk about
Maybe less.
With childhood cases, there is a little bit of a problem in differential diagnosis. Some of them, if it happens, and it happened to me, that is the first case in the family, could be misdiagnosed as dominant optic atrophy, because typically dominant optic atrophy would start before age 10. And some of them are not are not acute. They are just slowly progressive, are almost congenital. So it makes some problems in the diagnosis initially.
And as you've described, it's a very interesting group, but so varied, isn't it? Where you have like young kids that are seen at the age of 2 with bilateral optic atrophy, and it turns to be labors, and everyone's gobsmacked that actually it's labors. And then you have others with this very slowly progressive course, and others who present with a classical, kind of very severe visual loss that don't do very well. So, part of the mystery is that we don't understand.
So we only have like a minute or two before we should go to break. If I could ask my microphone helpers to help me out, is there 1 or 2 questions related specifically to the 11778 late onset or early onset, one in the center here? And anyone else wants to queue up for a next question?
Not to muddy the waters, but I've got in my son's case, you can go back 3 generations, and in cases with maternal uncles that were smokers, heavy drinkers, nothing happened. And it seems that, at least my understanding now, is that there's been somewhat of a reconciliation between, when I was younger, between Lamarckianism and pure Darwinianism. And it seems that after they completed the human genome, they looked at the sequence and said, there's not enough there. And that metagenetics have now become kind of an intermediary between environmental factors and genetics. Is anything being done in terms of someone that you would think is purely a genetic case, but there may be a case that a great uncle was exposed to environmental stresses that then resurfaced a generation or 2 or even 3 later?
You make a good point. Epigenetics, which is the environmental effect in one time and even generation, can have consequences later on that seem to be genetics, could conceivably be the case. I don't think we have evidence of that. Doesn't mean it's not. But I think that the interplay as it is, keeping it a little simpler between genetics and environment, is quite complex as it is. And this is the point that was just being made by Patrick a minute ago. It's hard for us to study genetics when we don't have complete control of the environment. And it's hard to understand, in your particular case, the role of environment when you don't have complete control of the genetics. So while it starts so simple, this mitochondria that's passed 100% through the female line is what caused the problem. Well, what about the other 30,000 genes that are in the nucleus? They can have the opportunity of modifying this disease, coming in from both sides of the family, male and female. So it can get complicated enough that what predictably occurred in one individual is very unpredictable in the next.
You want to say something?
No, I was going to say that, Valerio, you probably have something to say about where things could merge in terms of smoking, really, isn't it?
So one of the things that we are planning to do, collaborating with the UK group, is actually getting aggressively on this issue of locating the nuclear modifying genes. And obviously, up to now, we were putting together all the affected people, mixing up people getting affected because they have been smoking for 30 years with people getting affected at 10 years of age because of a strong genetic determination. So what we're going to do next, we will be comparing the so-called extreme phenotypes. So childhood cases where genetics plays obviously a major role against people being carriers, smoking and drinking and not getting the disease because they're obviously super protected by something which must be in the genes again. So parsing these two extreme ends should be informative in locating some of the extra genetic factors on top of the 11778 mutation in the mitochondrial DNA.
Okay, so what we're going to do now is, it's 10 o'clock. We have a half an hour break. The team will still be here during the break, so if you have questions that you want to try and catch them individually during the break, you have that opportunity. We'll be back at 10:30. We'll go till 12, we'll have lunch, and then they will be back for more questions. So the issues we didn't cover in terms of other mutations, carriers, research, we'll cover that after lunch, and we'll do some more Q&A then also. So see you here at 10:30. Thank you.
Thank you.
So where I wanted to start now is go to different mutations. We spoke earlier, we spoke earlier about the 11778 men. Now let's talk about the other mutations. Could we talk a little bit about 3460 and things patients would want to know?
Well, certainly Valerio can add much more than I'm going to say because he can grow these cells in a culture. But the bottom line, the simplistic way of looking at it is 3460 is worse, just as 14484 is better. Now, what's interesting is even though there are a few ways that that's true in terms of likelihood for spontaneous recovery, the benefit of adiponone or other things working and so on, there's still a tremendous amount of similarity in terms of if you get it, how the disease looks. So we can't make the distinction clinically. If somebody comes to me without a blood test, I won't be able to say which of the three it is. But still, if it's 1444, it's a more optimistic point of view for both getting better by itself or getting better with therapy.
Right. So the three mutations cover 90% of patients. And biochemically speaking, 3460 is worse because lowers the activity of complex 1. And now that complex 1 has been crystallized as a huge, big protein with all these different subunits being assembled, we understand better the mechanism. So 3460 is in the subunit which interacts with the coenzyme Q carrier. The other two mutations, 11778 and 14484, are actually not lowering the activity, but they are reducing the efficiency of conserving the energy. So they're still doing something that produces a defect of complex 1. But just to give you some examples, as I would consider 3460 on one side and the other two on the other side, 3460 has the lowest male to female ratio. It is usually 3:1. And 11778 is 4, 5, 6:1, and 14484 is 8:1. So most of the patients with 14484 are essentially males. It's very rare to see a female with this mutation. The other thing, the two mutations, 11778 and 14484, are associated with a specific background. Significantly, if they are on haplogroup J, this particular background with other variants in complex 1, modifies the severity, not the severity, but the penetrance. So more people could get affected if you have the combination of the two mutations and haplogroup J. 3460 is not associated with haplogroup J, so it's strong enough actually to manifest as a disease even without other particular backgrounds or other factors. So there are many scientific reasons for differentiating these mutations. But I totally agree with Alfredo that when it comes to clinic and what you see in the exam, in the neuro-ophthalmological exam and in the progression, I would say that the disease is always the same. You hit first the small axons, then you get the medium, and eventually, if the situation is very severe, the larger ones. In 6 months, everything is sort of finished, and then you start having the chronic phase. You cannot really distinguish from that point of view. However, 14484 has a clear-cut highest ratio probability of recovering spontaneously. This is happening in particular if the age of onset is less than 20 years of age. So younger is better if you have 14484. Older people, if the disease starts in an older age, the capability to recover is pretty much the same for all three of the mutations. I think I said quite a lot. What about you?
No, essentially, yes. There's not much I need to add here that has not been covered. That the 14484 is really quite different in terms of the much higher rate of spontaneous visual recovery. I guess for 3460, the only thing is it tends to be a smaller group of patients. And certainly this male to female ratio that you mentioned, there are some studies where there are more females affected, but there are also other studies like the Anita Harding study from the UK where the male to female ratio is more like what you would expect. So I think that's not clear-cut because there's small numbers, these case series, not enough to perhaps make too strong judgments.
How about some of the other mutations beyond the top 3? What happens if somebody is tested for the top 3 and it's not there? What's the practical next step for that patient?
I'll just say two quick things about that. First of all, I sometimes get those referred to me, and they've done the blood test 4 times and come back with the same. It's not one of the 3. The blood tests are really accurate. Doing it over and over again in this particular case, I don't think has much benefit. 2 is that in the old days, we didn't always have these blood tests, and I don't think there was any ambiguity. We knew what Leber's was, and we still do. So it happens 5 or 10% of the time that I get the patients returned back without the 3 mutations being known, and I'm still sure it's Leber's, and it's one of the 5% that haven't been characterized. Although of those 5%, the number gets reduced all the time because and then that's what I do is I save the bloods, send it to him, and when he gets around to it, which might be a while, he will characterize the entire genome and find it for us.
Yeah. Nowadays is an easy procedure and relatively inexpensive to sequence the entire mitochondrial DNA. So we published a few years ago a bunch of rare so-called mutations, which are truly mutations, are not polymorphic variants. There are some criteria in order to prove that a variant is a pathogenic mutation, and now we know how to do it. So if the clinical picture is unequivocal, as Alfredo says, this is Leber's. I don't care if there is no classical mutation. It is Leber's. And in particular, if there is maternal inheritance, you are you're sure 100% that you're going to find some variant which is causative of the disease. The only thing is that the severity of this mutation may change depending on where the mutation is located. So we are now aware there are a bunch of mutations which can be heteroplasmic, and within certain amount of heteroplasmy they can produce Leber's. If the heteroplasmy is higher, and they can actually give other symptoms, and these are mixed phenotypes or overlapping phenotypes. And if you want, we can discuss a little bit that. But in many cases, you should do the sequence if you want to be very sure on something that is not blood, but it would be more useful the urinary sedimentum, the epithelium from the urinary sedimentum, or in the best, I mean, the gold standard would be in the muscle biopsy.
Did you have more to add?
No, essentially, I was going to say that's where progress has been made, because 10 years ago, people would say that the 3 primary mutations would account for 95% of cases, but now because people have more access to whole genome sequencing, it's probably 90%, because increasingly you find these rare mutations, yes, but when it comes to major centers, it's not that rare because it's a self-selected group of people you're doing whole genome sequencing on.
And then sometimes we hear reference to secondary mutations. And can you help us understand what secondary mutations mean to us as patients and whether you'd have just a secondary or two of them together?
Well, primary and secondary, it's sort of misleading. Now, we should talk about pathogenic mutations. So that mutation is a prerequisite for actually being predisposed to develop the disease. Secondary mutations used to be called secondary mutations variants, which now we know are polymorphic variants that are distributed in the population. So I personally have a couple of secondary mutations, but just because I belong to haplogroup T of mitochondrial DNA. Someone who belongs to haplogroup J has secondary mutations. So I would not call these secondary mutations. I would just call these specific polymorphic variants of the normal haplogroups. Then what we definitely demonstrated in a very reproducible way is that primary mutation, so 11778 or one of the others, on a haplogroup containing these variants that used to be called secondary mutations, they can synergize and modulate the severity of the mutation or the penetrance of the mutations. But pathogenic mutations is the only thing, the only terminology we should consider right now.
Forgive me, I don't mean to dumb down the response. Everything you said, of course, is correct, but it's easier to think of secondary mutations as just variations. You know, you got blonde, you're brown-eyed, you're blue-eyed. It's just a background situation. It doesn't cause disease.
Great, thank you. Can we talk a little bit about women now? I know we talked about it earlier, but can we go a little bit further onto the topic of women and just really focus on that? I think a lot of women find it's harder to get diagnosed since doctors are looking for young men, but can we talk a little bit of differences in terms of, you know, onset and estrogen? We talked a little earlier, but can we really focus on women?
As you mentioned, this is a group where sometimes the diagnosis gets delayed because the classical patient with LHON will be a young male, and therefore sometimes people don't think about it to start off with. There was only one study, perhaps Valerio and Alfredo will confirm that, from Anita Howding, suggesting that there was a difference in terms of age of onset with female carriers with the 11778 mutation, but that has not really been shown elsewhere. So I think that's the only case series I'm aware that has potentially shown that it's different age of onset.
Yeah, and that particular study by Anita Harding, the age of onset of women was shifted slightly later than males, which, but we need to run proper studies to demonstrate that, which could mean that you have certain amount of female getting the disease in the traditional age, like in a young adult age, and eventually a second hit in the postmenopausal period, or in specific clinical situations where you are not having the right amount of estrogens, like primary amenorrhea, or in the postpartum period. I have a few anecdotal examples of females actually getting affected after delivering the second or the third baby. So it's all anecdotal, and I would be very careful of making any statement about this. We need to run properly designed studies, epidemiological studies, so we need to investigate very large cohorts of people in order to produce a solid statistical relevant results.
Maybe just one simple take-home that might be useful. Women are less likely to get the disease, depending upon mutation, different amounts, but you're lucky in that regard. But if you get the disease, it's the same disease. They don't get a mild version of it.
Yeah, correct.
So then when it comes to getting the disease, that's a good segue to carriers. So can we talk for a while about carriers and what the risk of vision loss is for various carriers, different genders, ages, et cetera?
Well, the general figure that you will hear quoted is essentially if you're a man and you have one of the primary mutations, that your risk is about 50%. But of course, this will be influenced by other risk factors, like for example, if you smoke, because if you're a carrier and you smoke, then your risk is not going to be 50%, it's going to be nearly 95%, 100%, right? For female carriers, the risk is lower, it's 10%. But as Valerio mentioned, there are some case series where, for example, the 346 mutation, female carriers have an increased risk of losing vision, potentially because it's more pathogenic.
Yeah, the definition of carrier is someone who has the mutation and did not develop the disease yet, and possibly and hopefully will never develop the disease. So this has been one of the mysteries and is still not completely solved that we have been investigating in the last 10, 15 years. So the question is, why some people has the mutation and actually gets the disease and some other people is not. So one of the last findings that I believe are pretty relevant and in a sense are quite simple as an explanation is that the capability of develop a compensatory response to the mutation in carrier is higher than people that actually gets the disease. So this thing is possibly related to a genetic background, possibly related to the fact that some carriers are not smoking and drinking as the people getting affected. It's a very complicated interplay. One thing that I'm quite convinced and fits with the estrogen observation is that the compensation that carriers are able to carry out more successfully than the people having the mutation and actually getting the disease is based on mitochondrial biogenesis. If you have a system able to increase the number of your mitochondria in the presence of the mutation, you are more prone to maintain the mutation without getting the disease. If you are less able to do this business, then you're more prone to actually get the disease. Obviously, if you also smoke, drink, and do other things, despite your compensatory capability, probably at the end you will get the disease. So it's a very complicated interplay, but there are spontaneous compensatory mechanisms that make some people being the carrier, and this is a very important indication to use these strategies as a therapeutic strategies in the next future.
And so these are great directional avenues. What should somebody's eye care health plan be if they are a carrier? What should they do in terms of seeing someone?
Well, that's your...
Okay. There's a couple of reasons that I'm going to give this response. I think they should come in regularly and be examined. And one of the reasons is not for the carrier, but for humanity, for us, for research, for all of us, because we're going to be learning in the next decade, I think, more from carriers than for affected. And that's because we have now developed some tests that show changes in carriers too. So these changes are called subclinical signs. They're not obvious, they don't affect the vision, and that's by definition. If they affected the vision, we wouldn't call the person a carrier anymore. But being able to see the nerve fiber layer in certain areas swell and go away and certain color vision changes is, I think, going to tell us a lot about what's going on inside so that we learn about labors and hopefully do better next decade. The second reason is that there are going to be, probably in the near future, ways that we can modulate the disease that are going to be more important than carriers than even in the affected. Even the things we've talked about earlier today, don't smoke, don't drink, don't take these antibiotics. It might be important to communicate that. And even though I've seen many families come with some members of the family, when on the third visit they bring other members, by their questions it's clear they're learning from that interaction. So for those two reasons for sure, and maybe because in the near future we'll be actually treating carriers, we're not there yet, I encourage carriers.
And what about, are there other things that carriers can do to protect themselves that we didn't talk about earlier, things like head trauma to consider?
Well, again, this issue of head trauma is based on anecdotal case reports, and there is no firm evidence that if you have a head trauma as a carrier that this will precipitate visual loss. And also partly what Alfredo mentioned is if you've experienced this catastrophic event of losing vision in both eyes, people tend to look for a reason why this has happened. So I think the pragmatic thing is that if you're a labor carrier, is to avoid from any contact sport that's going to expose you to potential risk factor, more as a pragmatic position rather than there is hardcore evidence for this.
So if I understand you correctly, you don't recommend head trauma to carriers, but to everybody else you do.
I'm not sure what you do in your spare time, Alfredo.
Yeah, so no head trauma, no exaggerated exercise, physical exercise, no smoking and drinking, no being exposed to any kind of fumes. I mean, all the things that we have been talking about up to now.
Right. Is there anything someone can do if they're a carrier and they start being afraid something's happening with their vision and it might take them time to get to see you or a comparable doctor? Is there anything they can do?
I don't know. I have mixed feelings about the issue. On the one hand, we all have this instinct that if there's a good time to treat, you want to nip it in the bud, and earlier is better. On the other hand, I'm not convinced that really happens in labors. We've had too many occasions where a person has gone losing vision in one eye, put them on the medication that we really want to put them on before the second eye, and still watch the second eye go just as bad as the first eye, to make me think that it's just not really, at least it's not likely that we can nip this one in the bud. That said, I guess I still would like to have a person feel that they can reach me. There's at least two reasons for that. One is maybe that first statement I said is wrong. Maybe you can. It's worth a try sometimes to at least go over the antibiotics, all the issues that we've talked about. And secondly, I think it's really important that we study.
I think you're right. So far, there is no evidence that if the process has started, that there is a way of stopping it. And I think Valerio might know the latest, but there's certainly our colleagues in France where they were trying cyclosporine treatment to try and prevent the second eye, but as far as I know, it's not really been successful.
Yeah, well, this is a very long discussion. My impression is that once we understood in all details the pathogenic mechanisms, we will need probably a combination of different strategies, because on one side, just correcting the pathogenic mechanism, it takes time. So that's probably the reason why with the antioxidants, with the idebenone or with EP743, you need to treat the patients for months, for years, in order actually to reach some sort of result at some point. So these are not drugs that are able to abort the disease, to stop it when it happens. On the other hand, instead of just trying to correct the pathogenic mechanism, there might be in the next future means to keep alive the cell, whatever pathogenic mechanism is ongoing. So we should avoid cells to be lost, to die. So if we combine a strategy where we keep the cells in place and we take time in order to correct the pathogenic mechanism, a combination of two things, that probably will be the successful strategy. That's my gut feeling.
One other thing I wanted to add to this point, that is that the carrier is still, like anyone else, apt to get mild eye disease. And while most people, when they get mild eye disease, say, it'll go away or it won't matter, naturally the person who comes from a family of labors is going to be very much more concerned. So to that point, there are a couple things that carriers can do to find out if this is the real thing and serious or not. And one of them is to check each eye individually. If you're looking together, your good eye will sort of mask any defect in the bad. So looking at things, covering one eye, covering the other eye is helpful. The first symptoms for labors, as everybody in this room I'm sure already knows, is either a dark spot in the middle of your vision, or maybe more subtly, the very earliest, is an inability to see bright color, particularly bright red. So that if you had a red scarf or a red hat and it looks red with one eye, but with the other eye it has become a pale orange, that would be the real thing. But if you've got floaters, and half the people in the world will sooner or later get floaters, a little bit of dust that's floating about in your eyes, then you need not panic.
Okay, let's turn to research. Everybody's always interested in what's going on in the field of research. What can you share with us about research?
It's going on. It's certainly alive. I'm not sure it's well, but there are a number of different trials that will be coming along. These trials will go from genetic therapy, a very legitimate approach towards this. The easy gene therapy that you hear about is when you want to change something that's part of the nuclear genes, one of those 30,000 genes. The hard one is when it's mitochondrial genes, one of those 13. Nonetheless, with a few tricks, people have figured out, at least theoretically, how to go ahead and proceed. So there are gene therapy trials going on right now, just starting, and there will be more trials starting in the near future. So that's one approach. Another approach is going to be in this class of medications that we've touched on all along. That class of medications are called quinones. I think Dr. Carelli a few times referred to it as antioxidant type medications, and that's exactly what they are. So coenzyme Q10 was the first of those, not so good. Idebenone was the second, somewhat better. There was a trial of something called Epi-743, and there'll probably be some others coming along that are second, third, fourth generations of that. There's also other medications that are novel and unproven, but who knows? And so there will be some other trials going on. There's a group in Massachusetts, Stealth, that will probably begin this trial in just another month or two. That might even work out to be in eye drop formulation. Works in an entirely different mechanism. And I am sure that in the next couple of years we'll see some more trials started. People are on the task.
Yeah. Speaking of trials, what is our thinking in Italy? Obviously, we look at all these trials with great interest, but our personal point of view and effort in the direction of some therapy for labors is very much concentrated on this compensatory response that spontaneously carriers are orchestrating. And we are trying to simulate or to enhance this sort of response, helping the people not getting affected. So phytoestrogens has been a study which was sponsored and paid off by UMDF, and it's now finished. We are writing the paper. A combination of phytoestrogens are actually very helpful in reaching a result which is pretty much the same as administering estrogens. But obviously we cannot give systemically estrogens to males. So this will be some sort of possibility in the future. And besides estrogens, you have other molecules able to upregulate mitochondrial biogenesis, so to make more mitochondria. For example, you have vitamin B3, and there is a lot of discussions in the field, not only for labors, but for many other disorders, mitochondrial disorders, of just enhancing the amount of mitochondria, because this is a compensatory response itself that in labors, which is after all considered a weak mutation, because you get the disease only one cell type compared to the other mitochondrial diseases, it could be the playground, the most successful case for applying this approach. Then we are still very much trying to dissect the pathogenic mechanism in cells. The last thing that we have been doing recently is to generate neurons from fibroblasts. There is a technology where you get the skin biopsy from the patient, you grow fibroblasts cell line, you produce stem cells from these fibroblasts, and you produce neurons from these fibroblasts. So step by step, you are actually having the opportunity to look at the right target tissue, which has not been done up to now.
But I think it's really important to be clear here. Sorry, Larry, for interrupting, but not therapy. He's talking about experiments. He's talking about ways to study the disease. These are not stem cell therapies.
No. It's not stem cell therapies. This is a research program actually to generate the cells which are affected in the disease in vitro, in an artificial system.
I think we're all talking about treatment here, which is really exciting because 5 or 10 years ago, we would not be having this kind of conversation. I think different techniques are being looked at, whether it's antioxidant, whether it's improving mitochondrial biogenesis, whether it's gene therapy. But in the end, also, what is very clear is the fact that we're dealing with a rare disease, and the reason why we're here sitting in this room talking about labors, different countries being involved, and clinicians, is that we will need these kind of multinational collaboration to be able to have enough patients to recruit into these various studies. And we're also still struggling, to a certain extent, about how long the treatment will have to be, what outcome measures we need to use to be able to find the treatment effect. So finding potential treatment is one thing, but also how we're going to be running these clinical trials also needs a lot of careful thought.
What I'd like to do now is open it up to the audience for questions. If I can get my microphone people back to work, and if anyone has questions for the panel, please raise your hands high so they can see you from the back of the room.
It's going to be any question.
Any question? Thank you for clarifying. That got more hands. Any question, any topic for this panel?
I have two questions. One is really, really quick. If somebody is taking 900 milligrams of idebenone and you kind of break it up 300, 300, 300 throughout the day, how much vitamin C possibly should they be taking in
Boy, that one's simple.
in concert?
500 milligrams is probably plenty.
For each time?
No, eat once a day.
Just once a day is okay?
So
Okay.
let me exploit your question for one more point. We've been saying, I think, unfortunately, 900. That's not what really matters. What really matters is how often you take it. Because it's not like an antibiotic that the more you get in there, the more effect it has. If it works to change the metabolism, it works because there's no absence of it. So some people think, well, gee, if I take 300 3 times a day, it's so cumbersome, I'll just take 450 twice, or maybe 900 once. Doesn't work that way. Spread it out. On the other hand, vitamin C, if you take one 500 milligram tablet, it'll be there all day long.
Okay. All right, good. Thank you. The other one I wanted to ask is my mutation, my family's mutation is 15257. So, it was called secondary when we got it. Does that mean that we really have one of the three main ones? We just weren't able to detect it at Athena?
So you just have the 15257.
That's all that showed up on
So
on
you
our
don't,
lab
that
results.
doesn't produce the disease. You're missing your mutation. You have to rerun the genetics, possibly sequencing the entire mitochondrial DNA.
I think you're one of the 10% or 5%
Okay.
that isn't.
Because my mother-
Is it maternally inherited in your family?
Excuse me. My daughter was affected, and then we looked back at my birth family. I was adopted, and oh no, nobody except for my great uncle who lost his vision because of diabetes. But that was a way long time ago, and he probably was affected. They just thought it was
But
diabetes.
is maternally inherited? It's true females.
Excuse me?
Is maternally inherited?
yes,
It's true
yes,
females.
yes. It
Okay.
was my
So then
grandmother's brother.
you probably need to run the complete mitochondrial DNA sequence, and
Again?
you're gonna find something, because they just tested single mutations. They didn't find any of the three, and at the time you did this, probably 15257 was still considered a candidate for being a primary mutation, but
Okay.
that's not enough.
Okay. 'cause this
Basically,
was-
Athena doesn't look except for the big three.
Right.
And so you're one of the 5 or 10% that they shrug their shoulders at.
Yeah, okay. Because they did put that number on there. I just didn't, so that's what we've always gone with. But, and that was 5 years ago. So if we run it again,
Same thing. You would want to send your bloods to somebody who does this whole genome, much more complicated, much more costly.
Okay.
But that's how whole mitochondrial genome, thank you.
Okay.
That's how you get the 5 or 10%.
Okay, I'll try to find out who does that then.
We'll get to that in the very next session.
So my question is also on genetics, but so I was also adopted, but have since found the birth family and a mother or a sister to share a common mother, and she's concerned about the chances that she also is a carrier, and so my question is, how often does it spontaneously appear? Is it potential that I'm kind of a carrier and affected without having the mother also passing it on to my siblings?
So if I understand the question, your mother's sister.
My sister and I have the same mother.
His sister.
Right, right. So essentially, and you have been confirmed to have a primary LHON mutation? Yes. Right, so I think in this case, it would be important for your sister also to have the genetic diagnosis confirmed, because it's very rare to have de novo LHON mutations been reported 2 or 3 times before. So the chances are that it's come from your mother, but certainly I think your sister should have it tested.
More questions?
You've mentioned carriers and they are at risk. Have you any thoughts on whether a carrier should take antioxidants as a routine, or do you just think it's not worth the cost of buying antioxidant vitamins?
I mean, take the cheap ones on routine. But eat your fruits and vegetables even more so, because I think it's all the little in-between antioxidants that count. But what we did already discuss, and just to be really clear, is I do not believe the carrier should be on idibinone. Not yet.
Yes, I'm from a large family, and we've been following for a number of years research in the field, trying to bring to light what we can do and what we can't do and what we can expect. But so looking at some of the trials, and we do the best we can up in Canada to track what's going on down here, and we do have a few researchers who are involved in some of the big studies. But I noted in the research work that my other family members have given me that some of the work done by you, Dr. Sadun, has been terminated without explanation. This is the Edison pharmaceutical where it showed promise from a regaining of.
That is correct. And,
so could you please give me
an
update
Obviously,
on some of these?
It's a little bit awkward for me to be to explain their decision-making, but I can certainly say that we're talking about Epi 743. It's a third-generation quinone that it has been used in a dozen patients that we've had in the U.S., in addition to which 3 patients that Dr. Carelli has seen and 6 that we've done together down in Brazil. And the results were sort of similar to, but at least as promising as idibinone. So it's a disappointment to us that the trial has been terminated. But it wasn't the best thing since sliced bread. It wasn't the magic bullet, as Patrick mentioned it before either. So it's not clear why they're not extending it, but that's it. It's their call. They're not making the medication, and it's not available to us. All I can say is that it's a sincere decision on their part. It's made by the Edison company, who's the only source of this medication.
Yeah, and eventually the results of these patients being treated will be published once are completely analyzed.
And it does raise what the difficulties we face when we're dealing with rare diseases and where there's limited drugs, potential drugs out there, that to a certain extent, we have to start with these smaller open label case series to see whether it's safe, whether it's having some effect, and then move on to the bigger study. But moving on to the bigger study is a huge financial implication. So even if we as researchers want to go to national organizations to have it funded, not via companies, but from research money, it's very difficult to get that sum of money funded.
Yeah, for a company jumping from the open label trial to the real one, placebo-controlled, is an important decision from the economical point of view, and sometimes there are some considerations for not pursuing that particular thing.
That's why it's so important that you have these gatherings, because one of their perspectives, I'm not trying to say that this was necessarily Edison's perspective, it's unfair to imply that, but one of the perspectives might be, gee, that's such a small market. And so it's good that you get together, and it's good for us as researchers to point out that what works sometimes in a disease that's really well understood but tiny can be extrapolated to other diseases.
I have a question for Dr. Carelli. I'm very interested in mitochondrial biogenesis as a compensatory mechanism to overcome the complex 1 defects in LHON patients. And I was just wondering whether you could comment on how you think that's happening in unaffected carriers.
Well, The obvious answer, but I don't have the exact details on that answer, is that there is a genetic setup that makes that particular person, individual, more efficient in carrying out this response. And in the paper where we actually described this response, we tried a bunch of genetic variants in some genes, in some proteins that we thought were very interesting candidates for being more or less efficient in carrying out mitochondrial biogenesis, but unfortunately none of those variants was associated in a statistical, meaningful way. But this is our primary theme of research. So you will have, I hope we're going to have some answers in the next years. I mean, UK is doing the same thing.
We work very closely with Valerio, and I think what we've been discussing is one about treatment, but I think the other area which we've been touching upon here is really about providing better genetic counseling, because if you're a carrier with one of these primary pathogenic mutations and someone tells you your risk is 10% or 15%, what does it mean? And we need to know more about how to build this big equation about how you input the mutation, your age, your sex, whether you smoke, whether or not you're able to increase your mitochondrial biogenesis when you look at copy number in your blood samples. How does it all come together? Because the more we seem to know about the disease, the more all these factors are complicating matters for us.
Yeah. For example, up to now, we did not validate a test for mtDNA copy number as a test for to be actually done routinely in patients because there are some technical issues. But there is a new technology coming up which is called digital PCR, where you can actually do such a quantitative assessment, and we will try to develop a test for that. So the point is, once for a carrier, we will be able to say, okay, you have the mutation, the primary mutation, you have or you do not have haplogroup J or other haplogroups, you have a certain amount of mtDNA copy number, you have OCT scoring of fibers being swollen or not, and all these different things all together, we hope to produce a sort of a scoring system so we can actually predict to the carrier, okay, you're very close to have the disease or you're doing very well, and up to now, so far, very good. So this will be a predictive possible tool for carriers, which would be very important.
Hi. One of the difficult things about LHON, and maybe one of the good things about LHON, is that occasionally you do have spontaneous return of recovery of some or all of your vision. In the mutation 14484, when you do OCT studies, kind of before, after, and then kind of maybe a few years later, is there a change in the actual retinal layer thickness as the vision recurs or not?
Yes. But maybe I should be clear about two things. One, even in 1444, which has this highest and maybe the best in terms of how much improvement you can expect, I've only seen one patient that I would say had a full recovery, that everything returned to normal. And that person also had the benefit of treatment and the benefit of being a child. They had everything going for him. So I think that it would be misleading to suggest that 1444 is recovered. They just improve somewhat, sometimes. Two, the OCT, it's a structural measure of how many fibers you have, but before the fibers die, they swell. So the first thing you see when a person's affected is too much fibers, not too many, but too much. And then they start to settle down, and you might think the swelling's going away, that's great, but sometimes, in fact, usually they go way past it and shrink down, and you say, oh, that's terrible. The one thing that you can do is say, the thinner that is, the less potential for recovery. So even a year out, the 1444, if he's really thin, I'm very pessimistic, but he's got a lot of fibers left, he's the one who might recover. But a lot of fibers is never all the fibers. You can never reverse back towards normality.
Yeah, I can add one more thing. Some of the studies that we have been carrying out in Italy indicate another anatomical factor that seems to be relevant, which is the dimension of the optic nerve head. So 14484 are usually having the largest optic discs compared to the others. And that could probably be one of the other factors making this mutation more prone to recover vision. So having more fibers left after the acute phase and having a larger disc are the two things that anatomically will predict if you're actually regaining some vision or not.
Just time for another question or two. Anybody want to? Patty, we've got one over. Okay, Christine.
As an affected person, I've been on a Debanon 3 years, and I know you told me, Dr. Sadun, that it's baby steps, and you have to be on at least 3 years. As an affected person, this very slow process, if we are to see improvements, what are the things we could expect to see as far as these baby steps go, to see if the idebenone is helping us?
Let me change your question a tiny bit so I can answer it. What I can see when you come in is that black spot that's in the center of your vision. I can measure the boundaries of it, and it starts to shrink a little bit. And that's on your visual field. So we have measures, objective, quantifiable measures that the computer comes up with, which I can really hang my hat on. When the baby steps are small, it's too difficult for you to be able to perceive them, especially because they're diluted out over a period of a year. The final 2 points are that I have seen patients continue to improve on years 4 and 5, and 6 even. And therefore, the period of time that I probably would like to see you on idebenone is another 40 years.
Oh, and one other thing. You mentioned how bad smoke is. To an affected person, could being subjected to smoke, that could still, that's still a very bad thing for me.
We think so. We think that as this march goes from small to medium large fibers, anything that insults them, and smoke insults them, could march it further into the bigger fibers. So even though some things are lost, there's more that's there that you don't want to lose.
And you also said fumes. When you talk about fumes, are you talking about gas fumes?
No,
or?
smoke. Smoke from wood, smoke from charcoal, smoke from burning your steak, anything that is smoke, anything that's dark, that's up in the air, you don't want to have.
Someone mentions fumes. I don't know what they were referring to, anything. Okay, thank you, doctor.
Yeah, I have a quick question on the idebenone. Why is it, I've seen some people talk about they have a liver functioning test done. What is the reason behind that?
Well, this is an observation that came out from the various studies that have been done looking at idebenone, that certainly think about the Rhodos trial, there was only one patient where there was slightly disturbed liver functions. It was not very abnormal, it wasn't causing liver failure, but there was a suggestion that the liver function were heading the wrong direction. So it seems to be sensible as to have your blood check, certainly that's 3-6 months down the line, to make sure you're not developing any problems. There's also been this report of your white cell count decreasing, but I must emphasize these are rare events. Generally speaking, it's quite a safe drug.
And I guess my last question is, how did they come to 900 milligrams a day? Like, why not 2,000? How did they come to this number of 900 milligrams a day?
Definitely not makes sense.
Well, I don't have the answer. You have to ask Santerra, but for all these companies will do these pharmacokinetic studies where they will be, first of all, treating, for example, a model, whether it's a mouse or a rat, to see what dose they're getting toxicity. But certainly, when it comes to idebenone, up to 250, as they've used in some trials, seem to be safe. But whether or not, as we've been discussing, the dose should be 900 milligrams, should be 450 milligrams, should be 2,250 milligrams, we don't have the evidence which one is a better dose. And you will only know that by doing another study and comparing 900 milligrams with 2,250, for example.
Yeah. there are some studies that we are doing. In reality, idebenone is getting broken down in other molecules, and this is something that happens quite fast in the body. So one of these molecules seems to be the one more active than the others in terms of therapeutic function. So probably it's not even idebenone itself, but some of the metabolites that are actually functioning on the long run.
But just to maybe finish with a almost jocular point, the most dramatic medication I think ever introduced that really works is penicillin. And the standard dose is 250 milligrams 4 times a day, which adds up to 1,000 milligrams, which coincidentally is 1 gram. If you think there was much more science to it than that, you'd be mistaken.
And I'm afraid we're out of time, so we're going to have to thank our panel for their, okay, great. Thank you, Ken. Thank you.